Now I'll be talking about the non-Hodgkin's lymphoma variety. So let's look at those easy questions and I'll zoom into the slide. The first one that you will notice is a repeat question from FMG exam. He gave a story regarding a patient having both hilar and abdominal group of lymph nodes being enlarged, like porta, hepatis, retroperitoneal lymph nodes, all were enlarged. And then the highlight manifestation that was given was especially this particular cell. If you look at the cell, it looks like alphabet U. So obviously, like, a couple of guys, they were under impression that maybe he's talking about Hodgkin's lymphoma. But then Hodgkin's presents with that classical Reed-Sternberg cell, the Dowley appearance, and more importantly, like the history would be of a child, and we'll talk about cervical group of lymph nodes being enlarged. Here it was a different group of lymph nodes, as I mentioned, and the cells which I'm talking about at the moment are called as hallmark cells. In fact, this was a difficult question, a PYQ, where hallmark cells are present with respect to non-Hodgkin's lymphoma. And the non-Hodgkin's lymphoma that I'm talking about is anaplastic lymphoma. In fact, this was a two-step question. उसने ये भी नहीं पूछा कि ये anaplastic cancer है. He said anaplastic carcinoma. He said what is the chromosomal swap that is responsible. So the chromosomal swap for this one would be answered as chromosome 2:5. And yes, I think we are good to go for today. So I'll focus now on those common one-liners as well that can be asked to you, like which is the commonest variety of non-Hodgkin's lymphoma and the commonest subtype seen in HIV positive patients as well. So what I expect out of you is be fast with respect to these answers because pretty routine information. Okay, ji. So starting with the first one, this is obviously diffuse large B-cell lymphoma. In contract with nodular sclerosis that we get with Hodgkin's, and then he's asked the one that is seen with HIV patients. So I hope you have been prompt in answering that. This would be immunoblastic lymphoma. Yes, guys, it is the immunoblastic subtype of diffuse large B-cell lymphoma that is to be remembered. We are on page number 125 at the moment. So this would be the immunoblastic type that I'm talking about. And for the next question, I think you would be simply laughing on this. Because this is a super easy one associated with Helicobacter pylori, that would be multoma, and you know that this would be a non-Hodgkin's lymphoma of the B cell variety. The next question that I'm covering is associated with HHV8. Now, moment I say HHV8, one that comes to your mind is obviously Kaposi sarcoma, but that would be for like a HIV positive patient. I am at the moment talking about one which is associated with Hodgkin's lymphoma. So your answer in this case would be given as primary effusion lymphomas. Very straightforward data, guys. So just keep commenting in the chat box with respect to these common questions that are asked. And the next one on the agenda. Yep. And the next one, yeah, I got Kaposi as an answer. That, as I said, is for HIV positive. What we are discussing is a non-Hodgkin's lymphoma at the moment. Then you said which is associated with hepatitis C virus. So the hepatitis C virus would be a marginal zone lymphoma. And the one which is like the favorite of your examiner and has been asked in last winter session, the January session, was hallmark cells. That would be anaplastic large cell lymphoma. Most of non-Hodgkin's lymphomas are B cell variety, but then there is one that is the T cell variety also. The technical term for the T cell variety would be called as cutaneous T cell lymphoma, CTCL. And this presents as like extreme redness all over the body. That would be in the form of a erythroderma. So in case he just mentions cutaneous T-cell lymphoma and only erythroderma, then I'll say that I'm dealing with mycosis fungoides. But if I add to this presentation, listen to the words very carefully. If I add to this presentation organomegaly, like I say hepatosplenomegaly, lymphadenopathy present in a patient, then I will say it is Sézary syndrome. So Sézary is the disseminated form. If the cancer is limited only to like the dermis, where the cutaneous, like the name cutaneous would obviously mean that we're talking about the security system of the T cells and the dermis of the patient. So as long as the cancer is limited to the dermis and there's erythroderma description, I'll say mycosis fungoides, where we also studied both in cut short as well as routine discussion that there would be microabscess formation that is called as Potier's microabscess. A lot of these questions can also be associated with यहाँ पे, that would be like this. यहाँ पे होगा क्या, पेपर यार इंग्लिश में होता है, तो आज थोड़ा इंग्लिश में बात करेंगे, हिंदी वाला जो है ना उसको कम करेंगे क्योंकि 5-6 लाइन की हिंदी नहीं होती, इंग्लिश लिखी होती है. The next one that आप देख सकते हो यहाँ पे, that's all I can use, right? The technical words will still remain the same, is a convoluted appearance of the nucleus. This convoluted appearance of the nucleus itself is a feature of like a Sézary cell that you need to remember, and is not to be mixed with, जो इसका अगला वाला है. In the अगला वाला you will notice that यहाँ पे जो nucleus है वो flower के shape में जा रहा है, like lot of convolutions which are present, and this would be adult T cell leukemia that is caused by STLV1. Usually they have asked about the neurological association of this condition also. The neuro association of STLV1 is tropical spastic paraparesis. And well, the hemat manifestation is right in front of you. That would be in the form of adult T cell leukemia, where we can see these lymphoblasts which are having these convolutions present, multiple convolutions in fact present, so would be easy to differentiate from that of Sézary syndrome. So okay guys, at this moment I think we are good to go for the common things that we have discussed. For those who joined late, मैं एक बारी फिर से repeat कर देता हूँ जो core aspects है. जो टॉपिक हमें पढ़ना है वो है नॉन हॉजकिंस लिम्फोमा. यहाँ पे जो प्रेजेंटेशन होगी दैट वुड बी लाइक इनिशियली ही माइट राइट सिम्टम्स आइडेंटिकल टू दैट ऑफ टीबी, जिसे कैटेगरी बी सिम्टम्स बोलते हैं. सो लाइक आई मीन व्हेनेवर यू रीड अबाउट कैटेगरी बी सिम्टम्स, दैट इज जस्ट अ डिस्ट्रैक्शन दैट इज प्रेजेंट, एंड देन ही विल टॉक अबाउट लिम्फ नोड्स एनलार्जमेंट. बट द ग्रुप ऑफ लिम्फ नोड्स दैट आर इन्वॉल्व्ड आर मल्टीपल, क्योंकि यहाँ पे हेमाटोजेनस डिसेमिनेशन होती है. And then another thing that can be given in this question is involvement of the tonsils. He might even mention clinically the involvement of the Walder's ring, that is like the tubal tonsil, lingual tonsil, adenoids, all of them can also get involved. So what I'm trying to tell you is a clinical kind of a question where at least 2 to 3 lines will be invested in these kind of details, and then he will mention the specifics. Like he will say excision lymph node biopsy was done. The investigation of choice for all the lymphomas is a excision lymph node biopsy, and then these slides could be given to you in the form of that hallmark cells that I mentioned initially, or it could be like the associations that I'm describing at the moment. So I think yes, I think we are settled at this moment for the pathology part, and some guys are going in a different zone में चल रहे हैं. Okay. So T14 is to translocation, that would be follicular lymphoma. ये in fact again is a question to be remembered क्योंकि 14 बार बार आ रहा होता है, राइट. सो एक बार प्रैक्टिस कर लेते हैं. बर्किट्स लिम्फोमा का बताओ जरा, राइट. बर्किट्स लिम्फोमा के लिए मैं क्रोमोसोमल स्वैप्स लिख देता हूँ 28 814. आप तीसरा बता दो मुझे, क्योंकि 14 उसमें भी आ रहा है. Burkitt's lymphoma is what you see with like Afro-American child, and then that Starry's का appearance ना, with that C by C gene abnormality present, which contributes to inhibition of apoptosis. So yes guys, 2 8 8 14, and the next one would be 8 is to 22 translocation. Yes, 814 तो बेटा मैंने बता दिया. 814 I have already explained to you at this moment, and then is the 822 translocation for Burkitt's. So 14 तो वहाँ पे भी आया था, but then subsequently 14 18 is for follicular lymphoma that you need to remember, and 11 14 for mantle cell lymphoma. Mantle will come up in the discussion subsequently also, but these are a couple of chromosomal swaps that I would like you to remember. So at this moment we are done with non-Hodgkin's lymphoma. Next we'll talk about some more cancers before we move on. जैसे नाम जो होता है ना, this can easily be a misnomer. Like if I take up a tumor like pheochromocytoma, तो pheochromocytoma पढ़ के लगता है कि यार this would be a benign tumor, but 10% of that is malignant. So कुछ तो pure benign होते हैं like lipoma, adenoma, these are the benign ones that we are talking about. But then subsequently एक manifestation जो पूछी जाती है उसका नाम है क्लोरोमा. तो आपने कमेंट करना है कि क्लोरोमा की बात कर रहे हैं तो which blood cancer are we talking about? And the hint is this image that you can see where the kid has presented with the unilateral proptosis, and you can obviously see the blood cancer cells also. I'll not mention the name there because then the cat is out of the bag. So yes guys, quick comments with respect to क्लोरोमा का जो association है, that is with which cancer. The hint is कि इसको granulocytic sarcoma भी बोलते हैं, और ये मैंने डिस्कस भी किया. We have already interacted about this. Very good, very good. Couple of people are spot on in this. Granulocytic sarcoma, chloroma is a presentation that you see with acute myeloid leukemia. तो ये नाम थोड़े lipoma, adenoma तो ठीक है, but chloroma पढ़ के लगता है as if it is benign but it is a malignant tumor. Then lymphomas again can disseminate both hematogenously as well as via lymph nodes. So is melanoma. Seminoma again can spread via lymphatics. In fact, like seminoma तो मतलब usually is asked with the undescended testis, and that cut potato appearance that we have talked about, fried egg appearance in the earlier discussion is very classical. Now, two images to be taken care of. One is with association with the blood cancer, that is acute myeloid leukemia. The myeloblasts are what can be seen here. And in this slide, those classical oil rods cannot be seen, right? So don't just rely on like the oil rods presentation to identify, because you need to link it up clinically. But if the question changes into a primary, like the question changes over into, the question says, what is the primary if I say anything, the answer becomes obvious. Obviously, it's a tumor related to the eyeball, but it's an extraorbital tumor. अब इससे आसान क्या करूँ? It's an extraorbital tumor in the eyeball of the patient, and results in this manifestation of proptosis. Again, not to be mixed up with the superior one, which was associated with the blood cancer. Yes, guys, waiting for answers here. Extraorbital tumor, क्योंकि दो ही पढ़ने होता है, एक तो इंट्राऑर्बिटल होता है रेटिनोब्लास्टोमा, जिसमें फ्लेक्सनर इंटेस्टिनल रोसेट्स होते हैं, उसका भी इमेज एक बार फिर से प्रैक्टिस कर लेंगे. And if I say extraorbital tumor, then this is going to be rhabdomyosarcoma. So what we're talking about is the topic of neoplasia. The first message I wanted to give was that नाम पे मत जाना. नाम जो है that can be like a impression that it would be benign, but turns out कि वो malignant भी हो सकता है. So जैसे मैंने क्लोरोमा का एग्जांपल दिया, pheochromocytoma, melanomas, seminomas, these are like tumors which are having a malignant potential, but the oma word can result in a false impression of a benign one. Then leiomyosarcoma or rhabdomyosarcoma, those terms also wanted to clarify. Leiomyosarcoma is what you read for the intestine, and rhabdomyosarcoma is for the skeletal muscle, like the one that I just showed you at the moment. Rhabdomyosarcoma is an extraorbital tumor with respect to children. So good. I think 131 is sorted. Then comes your favorite question. I think इससे आसान तो पूछ नहीं सकता. You can see the hair and the teeth, and it has a cystic presence on an ultrasound as well. That would be teratoma, and teratoma can be benign. Obviously, then we'll call it a malignant. Then we will call it a dermoid cyst. बट इसमें यहाँ पे जो दिख रहा है हमारे को जो प्रोट्रूबरेंस होती है, दिस इज व्हाट इज कॉल्ड एज रॉकेटेंसी प्रोट्रूबरेंस, एंड दिस रॉकेटेंसी प्रोट्रूबरेंस इज वेयर द प्रॉब्लम कुड बी हाइडिंग. व्हाट आई मीन बाय द प्रॉब्लम हाइडिंग इज कि यहाँ पे जो प्रेजेंट हो सकता है दैट कुड बी अ मैलिग्नेंट आई मीन ग्रोथ एज वेल. सो the image is a spotter. I mean, dermoid cyst teratoma is like super easy for anybody to identify. But what I wanted to bring to your attention is the malignant potential that it could be exhibiting. That's a solid mural nodule which is inside a cystic lesion, and the usual site of malignant transformation as well. और कौन सा cancer इसमें बनेगा, तो it would usually be squamous cell cancer that will be arising from the ectoderm. The message is it can be benign, it can be malignant as well. The tumor would be originating from the rocketency in the rocketency nodule. That's what the pathologist is interested in, basically, that they want to identify it as. I mean, why do we send a specimen to a pathologist? Is to differentiate between the benign and the malignant one. Then comes the aspect of hamartoma. Now, hamartoma, how is the question usually asked? One is the standard one that we discussed in cut short as well. It happens to be the commonest benign tumor, which will be having that appearance, which is also called as popcorn. So if I just say, I mean, cartilage in the lungs, right? And if I'm saying hamartoma, it basically means a haphazard proliferation of the native tissue. That would be from the, it would be origin from the cartilage in the lungs. And the classical appearance of this would be called as a popcorn appearance. So easy to identify. But in some questions, you might begin by saying coin lesion is noticed on a chest X-ray, because not in every section it will look like a coin. No? Maybe like when we do an X-ray AP or an X-ray PA view or lateral view, in some of the views it might appear in a round shape as well. So popcorn appearance is okay. The popcorn appearance is okay, but yeah, at the same time, in some of the sections, it can give you a coin lesion as well, and it happens to be the commonest benign tumor of the lungs primarily, most common benign lung tumor. Malignant बोल दो एक बारी फटाफट से. I know you know the answer, but just for the sake of it, primary malignant lung tumor. Very small squamous adeno and large cell cancer. The presentation would usually be in the form of a unilateral hydrothorax. A massive pleural effusion would be present. So yes, guys, what is the primary malignant lung tumor? Waiting for your answers there. Small squamous adeno and then large cell. ये तो आसान था सवाल यार, इसमें तो मुझे लगता नहीं है कि you would break a sweat there, right? So that would be adenocarcinoma. So the primary malignant one is, हाँ नहीं वो आ रहे हैं, errors आ रहे हैं. Adenocarcinoma is overall the commonest one, presents with a unilateral massive pleural effusion. और इसकी mutation पूछी थी. What is the commonest mutation? I mean this is a female patient. She's a non-smoker. She's never smoked in her life. वो कहते हैं कि मेरा brother भी smoke नहीं करता, मेरे dad भी नहीं करते. Passive smoking. I mean that's how a non-medical person will react to the news of a cancer that nobody in my family smokes. फिर भी cancer कैसे हो गया? So what is the common mutation which is responsible for developing the primary malignant lung cancer? Yes, yes, guys. म्यूटेशन, क्योंकि पैथो पढ़ रहे हैं ना यार, तो क्लिनिकल डोमेन में तो ऑब्वियस बात है कि मतलब आई कैन गो ऑन एंड ऑन रिगार्डिंग द प्रेजेंटेशन ऑफ यूनिलैटरल pleural effusion and then talk about pleurodesis and the therapeutic aspects. Okay, ALK gene came up, very good. TTF1 आ रहा है, वो रट्टा लगा रखा है आपने मैडम के नोट्स का ना, तो इस वजह से क्या हो रहा है कि मतलब जिस ऑर्डर में मैम ने बताया बस वो रट्टा लग गया है. Yes, guys, very good, very good. Subsequently, the answer came up. Sir, इसको गलत नहीं करना है. This is always asked in the exam. ये adenocarcinoma lung के लिए कौन सा mutation responsible है? So that would be EGFR1. जैसे आपको पता है EGFR2 is for breast cancer. They are hard to know. Similarly, EGFR1 is for adenocarcinoma of the lung. बाकी सब ठीक है, वो TTF वाला जो है napsin and all those things, because मैम का sequence I know that you guys are like totally into that, but sometimes the questions do not follow the pattern of the notes, and that is the logic of doing a class also today, right? ताकि जो भी मतलब छोटे मोटे फाइन ट्यून्स होते हैं, फाइन एरर्स होते हैं, they can be taken care of. I mean, why are we doing this today is to tell you simply that you need to be like proactive when it comes to doing questions. Okay, so next we'll talk about choriostoma. कोरियोस्टोमा का जो बेस्ट एग्जांपल मैं आपको दे सकता हूँ ना, दैट वाज अ इमेज दैट वाज गिवन. जरा जूम इन करूँ तो एंटी मिजेंट्रिक बॉर्डर पे कमेंट करो सारे के सारे. दिस इज अ पेशेंट हु वाज एडमिटेड विद द डायग्नोसिस ऑफ अपेंडिसाइटिस, बट अपेंडिक्स वाज नॉर्मल. Right? The guy was admitted with a diagnosis of appendicitis, right? Lower quadrant pain, he was feverish, he was puking, that typical Murphy's triad was satisfied, but the surgeon found that the appendix is okay, or like maybe he has already undergone an appendicectomy, but the guy is still having a manifestation, yes, on the anti-mesenteric border. So you can see that this is ectopic location of normal tissue. मतलब जो स्टमक का म्यूकोजा है, स्टमक का म्यूकोजा तो स्टमक में होना चाहिए ना. अगर स्टमक और पैंक्रियाज का जो म्यूकोजा है, if that will be located at 2 feet from the ileocecal junction, then this is not obviously normal. We are gonna call it a choriostoma. Either it's gonna be a stomach or it's gonna be pancreatic mucosa. That is one. And this is present at something like 2 feet from the ileocecal junction, because we always study the rule of 2 for Meckel's diverticulum. Then the technical word for from the pathology domain, I mean, we'll obviously call it Meckel's diverticulum, but the point is this would be called as choriostoma, ectopic location of normal tissue. ट्रेडिशनली जो हम पढ़ते हैं वो तो चॉकलेट सिस्ट ऑफ द ओवरी है, तो वो भी डिस्कस कर लेंगे. आई मीन दैट वुड बी एंडोमेट्रियम एट द ओवरी ऑफ द पेशेंट, बट देन द पॉइंट इज नॉर्मल टिश्यू एट एन एक्टोपिक साइट इज व्हाट इज कॉल्ड एज कोरियोस्टोमा. ग्रेट. इसकी इमेजिंग मोडालिटी बोल दो, फिर आगे चलते हैं. कोरियोस्टोमा के दो एग्जांपल्स जो हैं बड़े क्लासिकल वाले. One would be, in fact, I can write it like endometriosis and adenomyosis also, because again, the endometrial tissue would be present in the wall of the uterus. Normally, should not be happening. It should be the lining of the uterus only. So, yes, guys, the investigation that we'll be doing in this. There are three examples that I've written: Meckel's diverticulum, endometriosis, and adenomyosis. Endometriosis would be written as chocolate cyst of the ovary. You very well know that the bleed will cause that hemosiderin, and it's like brownish in color, so looks like a chocolate. Waiting for the imaging modality. हाँ जी, हाँ जी, हाँ जी. यहाँ पे जो इमेजिंग मोडालिटी है उसमें थोड़ा सा ट्विस्ट बस यही रहता है कि वो टेक्नीशियम 99 पर टेक्नेट स्कैन होता है. राइट, तो बस वो परटेक्नेट वर्ड याद रख लेना, बिकॉज उसको डाल ही देता है, राइट, इवन इफ इट्स अ पैथोलॉजी क्वेश्चन, he will incorporate the technetium 19 and pertechnet scan in the identification of Michel's diverticulum. So at the moment we started regarding choriostoma as a topic, and next up would be features of neoplasia. So let's just talk about neoplasia ke manifestations, and then I'll talk about difference from dysplasia. So neoplasia, like it's gonna spread. I mean, the cancer will always spread. So the question was very easy. He said, what is the most reliable sign of malignancy? It is obviously distant mets, and for these distant mets, we'll be doing a imaging in the patient also. Usually, the imaging that would be done in a patient would be a FDG PET. It is a 18F FDG PET scan that would be used to identify occult malignancy. For both the questions, whether he says the word occult malignancy, that is one. Or in some questions, instead of saying the word occult malignancy, he might say the word distant metastasis. Either of the two terminology is written in the question. You would say that, I will be doing a 18F FDG PET scan. FDG दो बार आ गया, so I'll just improvise on that. 18F FDG PET scan. वो एक्चुअली मैं पूछने की कोशिश कर रहा था, वही आपके एग्जाम का क्वेश्चन, थोड़ा रीइंफोर्समेंट है, जिन्होंने पहले सुना हुआ है वो शायद करेक्टली आंसर कर पाएंगे. ये जो F होता है, उसने पूछा था ये 18F जो है, what does it F indicate here? Yes, what does the F part indicate here? Options are fluoride and then fluoro. What does the F component indicate here? Yeah, it presents as a lower GI bleeding. हाँ जी, F वाला कंपोनेंट बता दो यार फटाफट से. जो दो ही ऑप्शन दे रहा हूँ मैं, या तो फ्लोरो होगा या फ्लोराइड होगा. तो हाँ जी, एग्जैक्टली ये जो फर्स्ट वाला है ना, दिस इज 18 फ्लोराइड. हाँ जी, दिस इज 18 फ्लोराइड. उसने पहले वाला पूछा था, उसके बाद वाला जो है दैट इज ऑब्वियसली दैट फ्लोरोडिऑक्सी ग्लूकोज. उसके बाद वाला जो है दैट इज ऑब्वियसली फ्लोरोडिऑक्सी ग्लूकोज, बट जो इनिशियल वाला है दैट वुड बी फ्लोराइड. सो मेटास्टेसिस हैपेंस टू बी द मोस्ट रिलायबल साइन ऑफ मैलिग्नेंसी, and except like basal cell carcinoma and glioma, which will be having like local spread. Basal cell carcinoma is what you read as a rodent ulcer, so it is locally invasive, and the image that would be given would be primarily in the tear wala area. Like basal cell carcinoma ka usually jo image based question aata, in that like the close up of the face of the patient would be shown, and जैसे हम रोते हैं तो आंसू वाला जो एरिया होता है वहां पे like जैसे टीयर्स होते हैं वहां पे there would be lesion present with pearly margins और rolled up margins. कैंसर जो होता है उसमें हमेशा pearly margins, rolled up margins present होंगे. So rodent ulcer is locally invasive. That's one of the common types of skin cancer, and will always be having that rolled up margins as is usually described. Then other features of neoplasia would be local invasion, high rate of growth, and then anaplasia. Anaplasia में सबसे important चीज है loss of differentiation, and then is breach of the basement membrane that will happen subsequently. And then cancer needs blood vessels also for growth. So there are two things which you need to remember: promoter of angiogenesis and inhibitor of angiogenesis. तो promoter तो पता ही है, vascular endothelial growth factor, for which we have anti-VEGF molecules also. But if he says the word inhibitor of angiogenesis for a malignancy, then the answer would be given as thrombospondin. Thrombospondin word हम पैथो में दो बार पढ़ रहे होते हैं. एक डिजीज होता है जिसका नाम होता है TTP, थ्रोम्बोटिक थ्रोम्बोसाइटोपेनिक पर्प्यूरा. उसका जो डिस्क्रिप्शन पढ़ते हैं ना, एडम TS13 deficiency, that is where we read about thrombospondin. And the second time we read it, thrombospondin, very commonly is whenever we're talking about promotion, when we're talking about comparison of promotion versus inhibition of angiogenesis. So these are the manifestations which are present. Yeah, EGFR1 is the most common one for, this is the common mutation for adenocarcinoma of the lung. Exactly, yes. Even ALK1 is responsible. Somebody had commented about ALK1. So there's a whole list that is responsible, but the commonest mutation is what I've highlighted. And next we'll talk about like how these cancers would be spreading. So most of the time the cancers would be spreading either via lymphatics or would be via hematogenous route. But then there can be exceptions to the rule. Like if I'm talking about lymphatics, the renal cell carcinoma jo hai, that will spread via the renal vein. The clinical manifestation of this would be tumor embolization. When I say like this, the query of students is, हैं क्या सर पल्मरी एम्बोलिज्म सुने हैं, एयर एम्बोलिज्म सुने हैं, आप क्या कह रहे हो ट्यूमर एम्बोलाइजेशन? यस गाइस, रीनल सेल कार्सिनोमा कैन स्प्रेड अलोंग द रीनल वेन, देन कैन गो इनटू द इंफेरियर वेना केवा, अलोंग द इंफेरियर वेना केवा लिवर में कैंसर के सेल, सोचो कैंसर के सेल का लाइन चल रहा है और वो renal vein set is going into the IVC, from IVC into the right side of the heart of a patient. So he can say tumor embolization would be seen with which of the following cancers? It is renal cell cancer, which can spread along the renal vein and can exhibit tumor embolization as well. Then obviously hepatocellular and a hot favorite of your examiner, follicular cancer of the thyroid with skeletal metastasis. I mean, ये तो याद करना ही करना है. I have always explained this. Pulsatile mets. बड़ी एक्सट्रीम बात बोल रहा हूँ. कैंसर, फॉलिकुलर कैंसर थायराइड will go to the skull, then it will destroy the inner table of the skull, then it will destroy the outer table of the skull. Inner table भी गया, outer table भी गया, so you get those pulsatile metastases. That is again a very favorite question of our examiner, because normally तुम पढ़ते osteoblastic, osteolytic, osteosclerotic secondaries, but this time we talked about secondaries which are pulsatile. I'll repeat my statement again. अभी पढ़ेंगे osteolytic, osteoblastic, osteosclerotic again, but before I do that, like a very peculiar statement is inner table of the skull भी गया, outer table भी गया, तो जो brain में carotid artery है, जो उसकी pulsations होती है, that pulsations are gonna be transmitted. Those pulsations are gonna be transmitted to like the tumor, and therefore pulsatile mets would be present. So lymphatic se all cancers will obviously spread except for a couple of them. The names are RCC, HCC, and then follicular cancer of thyroid. And then all sarcomas always have a hematogenous dissemination except for rhabdomyosarcoma and a synovial sarcoma. Question for all FMG students who sat for last time's paper. Tell me the radiological finding of synovial sarcoma. I have shown the X-ray of this to you. Just last week इसका X-ray दिखाया मैंने. Yes, waiting for your answers here. X-ray of the knee joint will be showing what radiological finding with synovial sarcoma. Yeah. Obviously, the dissemination part in RCC. So when we do the staging in RCC, we will take into consideration the spread by the IVC to the heart as well. Yes, guys. Yes. X-ray of the knee joint for synovial sarcoma. The radiological finding would be a snowstorm appearance. Yes. That chondroblastoma would be for that popcorn appearance. That chondrovala to sarcoma will be for that chondroblastoma will be for that popcorn appearance. But synovial sarcoma would be a snowstorm appearance that would be appearing. And this was like an image-based question, so I thought like just incorporate the same as well. And once we talked about the routes of spread, then comes what they again love to ask, that is direct seeding of the body cavity. Direct seeding of the body cavity would mean peritoneal cavity में. तो सबसे पहले तो पढ़ लेते हैं सूडोमिक्सोमा पेरिटोनाई, जो कि 2 बार पढ़ रहे होते हैं. फर्स्ट वी रीड इट विद द appendix, right? When pseudomyxoma peritoni is a appendicular tumor, because traditionally हम पढ़ते हैं appendicular carcinoid, but today I'm talking about a tumor of the appendix which can rupture, or we can be also reading this from the perspective of ovarian tumor which will burst, and therefore the mucin content will spread into the peritoneal cavity of the patient. So very good. Actually comments थोड़े late आते हैं, maybe like maybe like there's some lag between my relay. I mean मेरा relay तो हो रहा है, but आपका relay कुछ second बाद आता है. But anyway, good answers guys by you guys. And ovarian tumor and appendicular tumor, when they will rupture, they will cause spread of mucin into the peritoneal cavity of the patient. So that's like one of the direct seedings that we'll come across. Next comes the aspect of transcoelomic spread. In transcoelomic spread, the best example I can give you is stomach cancer. Like you can see stomach cancer, it can fall on the ovary, or it can go into the pouch of Douglas. Pouch of Douglas would be like the most dependent part in the human body in both men as well as women. It would be like separating in women the vagina from the rectum. So involvement of the pouch of Douglas can happen. That is what is referred as Blummer shelf. The shelf would mean like the word Blummer shelf is a technical term. It indicates that the pouch of Douglas gets involved. Then the cancer can be falling on the ovaries of the patient. And here, like Krokenberg tumor, the histopathological finding is that classical signet cell appearance. In signet cell appearance, what will happen is that the cells that will be present, उनका जो न्यूक्लियस होगा वो बाहर की तरफ पुस्ट आउट हो जाता है. थोड़ा कलर मुझे उल्टा यूज करना चाहिए था, पिंक एंड चलो कर ही लेते हैं, सो दैट डजंट कॉज एन इशू, राइट. सो इसमें जो सेल्स होंगे उनका जो न्यूक्लियस होगा दैट वुड बी पुश टुवर्ड्स द पेरिफेरी, दैट इज अ सिग्नेट सेल अपीयरेंस, and that would be drop down metastasis that is seen with ovarian cancer. And then the third example which is present for this transcelomic can be like not exactly I'll say coelomic word, but then craniospinal axis spread, क्योंकि मेडुलोब्लास्टोमा जो है वो सबसे कॉमन पोस्टीरियर फोसा ट्यूमर इन बच्चा है और वो सीएसएफ में स्प्रेड कर जाता है. तो आपको दो याद करने होते हैं, एक तो मेडुलोब्लास्टोमा के लिए क्रेनियोस्पाइनल एक्सिस स्प्रेड एंड वी विल डू अ लंबर पंक्चर एंड सीएसएफ साइटोलॉजी फॉर डिटरमाइनिंग द मेट्स, और दूसरा इसमें क्लासिफिकेशन यूज होती है. द क्लासिफिकेशन दैट इज प्रेजेंट हियर इज कॉल्ड एज Chang classification. So these are like tumors which are present at one side but then will disseminate to a distant site which is anatomically close. Like medulla would be very close to the fourth ventricle of the brain, so craniospinal axis spread of the cancer would be occurring. So that's like the term that we describe for the transcelomic spread. And lastly is a term peritoneal carcinomatosis or omental cake. नाउ इसके मल्टीपल रीजंस होते हैं, बट अगर वो सबसे इंपॉर्टेंट कारण पूछता है कि व्हाट इज द नंबर वन रीजन फॉर पेरिटोनियल कार्सिनोमैटोसिस, क्योंकि देखो मेडिसिन में तो हम जो वर्ड यूज करेंगे इसके लिए, द प्रेजेंटेशन वुड बी दैट ऑफ malignant ascites, and usually in a textbook like the image would be given of a lady with a huge abdominal distension. I mean ऐसे कि ह्यूज मतलब 2 किलो का तो ओवेरियन ट्यूमर होगा और उसमें लाइक 5-6 लीटर फ्लूइड इन द पेरिटोनियल कैविटी इज प्रेजेंट. सो व्हेन वी डू अ डायग्नोस्टिक paracentesis in a patient, malignant cells are found, but the term that's used in pathology most of the time would be peritoneal carcinomatosis for ovarian cancer. Yes, the most common ovarian cancer, कमेंट तो किसी ने किया ही है, थोड़ा पूरा कर देते तो और अच्छा रहता. That the commonest ovarian cancer that would be responsible for this presentation would be serous cyst adenocarcinoma. Overall, the most common tumor that we come across from the ovarian perspective is serous cyst adenocarcinoma. Then is the aspect of bony metastasis, which is for prostate and breast cancer, and both of them would be spreading via the Bateson plexus. The most common site of spread of prostate is lumbosacral spine. अगर वो प्रोस्टेट का पूछता है मेड्स कहाँ पे होते हैं तो lumbosacral spine. And if he says what is the common site of metastasis of the breast cancer, then happens to be lumbar spine. The common vertebral plexus is what is called as Bateson plexus. Now comes the aspect of bony metastasis. Bony metastasis में what I distinctly remember is कि osteoblastic का जो best example है that is carcinoma prostate, but MCQ में उसने osteoblastic नहीं लिखा था. An alternative term that was written was osteosclerotic. तो चाहे वो osteoblastic word लिखे चाहे वो osteosclerotic secondaries लिखे, आपका जो आंसर रहने वाला है that is prostate cancer, which is a adenocarcinoma. If he says which cancer can be both osteoblastic and osteolytic, so both breast and prostate would fit the bill. But if he specifically focus on osteolytic secondaries, then two that will always take the number 1 and number 2 spot in MCQ answers would be renal cell carcinoma, which is usually forgotten, that is clear cell carcinoma, and second is follicular cancer of thyroid. I repeat the data once again. Osteoblastic was written as osteosclerotic. Answer still remains the same, prostate cancer. Prostate can be both osteoblastic as well as osteolytic, so can be the issue with breast. So unlikely that they'll put up the second information to you. Either they'll put up the osteoblastic one or they'll put up osteolytic, and it's usually the osteolytic that the people tend to forget more often. So I'll re-emphasize that renal cell carcinoma and then follicular cancer of thyroid, both of them in RCC and follicular cancer thyroid, both of them are like the osteolytic secondaries that have to be remembered. Okay, then are the genetic mutations that we will revise. As already explained to you, EGFR1 mutation would be for adenocarcinoma of the lung. EGFR2, we are on page number 135 at the moment. EGFR1 would be for adenocarcinoma of the lung. EGFR2 is carcinoma breast, for which we are having these drugs also that we are using, trastuzumab. Then comes the issue Rett gene. Rett gene on chromosome number 10. This I teach in medicine part also. Red gene or chromosome 10 would be related to one development of multiple endocrine neoplasia, MEN2, especially where there's a gain of function that would be present. For MEN2, the tumors to यहाँ पे present होंगे, they can be remembered by a mnemonic by the name of PPM. So let's just quickly revise the tumors that we'll be finding in MEN2, and one of these tumors will not be present in MEN3, which were formerly called as MEN2P. So Sippel syndrome में जो tumors present होंगे, there would be one in the form of a parathyroid adenoma, which will explain why recurrent kidney stones could be the presentation in these patients initially. Then is obviously pheochromocytoma. Then is medullary carcinoma thyroid, which is well known by its tumor marker, that would be calcitonin. So PPM is the mnemonic that we study for these cancers. They usually mix up the data for MEN1 versus that of MEN3. And in NEET PG, they had asked regarding what is not a component that is seen with the MEN3, that would be a parathyroid adenoma. Okay, fine. So at the moment, like we now focus on c-KIT mutation, that is CD117. The mnemonic for this is well-known games. So GIST, that would be a gastrointestinal tumor that will be originating from that interstitial cell of Kegel with a special tumor marker that is called as DOG1. So that would be the first in the games component. A would be for acute myeloid leukemia. Then is mastocytosis and malignant melanoma. And S would be for seminoma. All of them would be having c-KIT mutation or CD117. Mnemonic is games. We can try and remember that again. GIST, acute myeloid leukemia. M would be for melanoma, malignant, and mastocytosis. Then E silent, and S would be for semin. Okay, good. ALK mutation comes with respect to adenocarcinoma of the lung and anaplastic lymphoma, two of them. Anaplastic lymphoma was discussed earlier also, where I'll zoom into the slide. And error done by a couple of students were that they called it a Reed-Sternberg cell, but if you look at the cell, it's more of a horseshoe shaped nucleus. Na? मतलब उसका जो nucleus है, that is like not having any prominent nucleoli present. Like suppose I drew a cell like this, and then I showed prominent nucleoli. I mean, then we say, okay, we're dealing with Reed-Sternberg. But the one that I've shown at the moment, that U-shaped or like horseshoe-shaped appearance, not that, I mean, obviously we are not discussing at the moment that Langerhans and Langerhans, that will also come up in the subsequent part of the discussion, but hallmark cells with a horseshoe appearance is seen with anaplastic T-cell lymphoma, CD30 positivity. The chromosomal swap for this was T2:5. Then is KRAS. KRAS comes in following cancers, that is colon cancer, pancreatic cancer, and lung cancer. So K and C usually can be rhyming. These are like couple, you can call it like COUPLE couple mnemonic. So colon, pancreatic, and lung cancer is where the KRAS couple would be spending their time. Then is CMYC, LMYC, and NMYC. Okay, fine. We call it Murphy's Law most of the time. Whenever you hope that things would be going fine, that is when Apple tries to throw in a tantrum. Okay, so next one is Burkitt's lymphoma for CMYC. LMYC would be for lung cancer. And then NMYC, and then is NMYC. NMYC would be for neuroblastoma. I think it would be working, guys. It should be working. If we can just close and start again, we can just close and start again. It should come. It should come. No, no, it should be coming, guys. Because it shows perfectly fine audio on my part. Just refresh. Okay, fine. So starting with the CMYC, the association to be remembered is Burkitt's lymphoma. LMYC would be for lung cancer. And the next one is NMYC, that is for neuroblastoma. And then comes ABL. Yes, guys, can I have answer for next one? BRAF is very, very enticing. So I'll just like you to hold on that at the moment. Yes, guys. Yes, CMYC is Burkitt's lymphoma. Perfectly fine. BCR ABL. अब तो बोल ही दिया ना, BCR is break child region and ABL would be Abelson leukemia. That would be for chronic myeloid leukemia. So we're just revising the important mutations, the must know genetic mutations is the table that we're starting at the moment. And we are done with like ABL at the moment. Next would be this aspect of BRAF V600E. That would be for papillary cancer of thyroid. Most of the time, the important risk factor for this would be radiation exposure. So most questions might mention like the patient is a nuclear scientist. He works at Baba Atomic Research Center and has come with a solid or has come with a swelling in the neck. When you put your hand on the swelling, it is stony hard in consistency. Any cancer that is stony, growth that is stony hard is probably a tumor. And turned out your worst fears to be true because the histopathology in this case showed that orphan NEI appearance. The slide of orphan and NEI appearance has already been shown, so I'm not getting into that slide at the moment. The next one is a tumor that is found in children. This is one of the benign tumor of the brain that is found in children, that is pilocytic astrocytoma. The reason why it is usually asked is one, that obviously this is a benign tumor in children. Second is for that histopathology finding of Rosenthal fibers that can be sent. Then yeah, all of them, right? The word is BCR-ABL. The word is BCR-ABL transcript, which is that abnormal transcript that causes formation of, or that causes the shift to left. So all the cells will start multiplying, myelocyte, metamyelocyte. I mean, chronic वाला leukemia MCQ, how do you pick up is कि सारे खानदान के cells लिखे होते हैं. उसमें myelocyte, metamyelocyte, promyelocyte सबका नाम लिखा होता है. So shift to left is the best way to identify like CML in any question. And obviously the second hint in the question would be that the size of the spleen would be outrageously long, massive splenomegaly. Along with that, the question will mention regarding vitamin B12 levels to be elevated and neutrophil alkaline phosphatase score to be low, because यहाँ पे neutrophils जो होते हैं ना, they are past their expiry date, मरते नहीं है. So chronic myeloid leukemia में जो hints रहेंगे, that's like pretty easy. In fact, the question उल्टा करता है. He will give you all this information by himself. And then he will reverse ask you, okay, which of the following is responsible for formation of this hybrid oncogene, BCR-ABL transcript. That would be like the end point of the question instead of being the starting point of the question. And BCR की जो full form पूछी किसी ने, तो वो होता है break chain region, और ABL होता है Abelson leukemia. BCR is break chain region and ABL would be that Abelson leukemia, which is to be remembered. And coming back to BRAF would be for papillary cancer of thyroid, pilocytic astrocytoma. Then would be hairy cell leukemia, HCL, where trap positivity is given. Usual question will say trap positive cells, that is tartrate resistant acid phosphatase positive cells would be present with hairy cell leukemia. And then is LCH, that is Langerhans cell histiocytosis. For the Langerhans cells, we'll be speaking about it even subsequently. LCH is Langerhans cell histiocytosis. So four examples, four names to be remembered for BRAF V600E mutation. That would be papillary cancer of thyroid and pilocytic astrocytoma. TRAP positive cells of hairy cell leukemia, and then is LCH, Langerhans cell histiocytosis. LCH is famous in pathology because of that aspect of Birbeck granules. No? CD1A positivity and Birbeck granules on electron microscopy in Langerhans cells. On Langerhans cells, that would be having a tennis racket appearance. I'll tell you hacks also how to remember Langerhans may or Langerhans may confusion now. So hold on to the different part of the discussion that we'll move on into. But at the moment, just wanted to finish this important mutations for cancers. And then cyclin D is famous for like association with mantle cell lymphoma. The chromosomal swap The chromosomal swap for mantle cell lymphoma was also discussed. I can just show you that slide initially. For mantle cell lymphoma, that would be 11:14 translocation. तो एक ही जगह पे सारा डेटा अगर लिख लिया जाए तो थोड़ा सा याद रखने की कैपेसिटी इंक्रीज हो जाती है. Okay, follicular lymphoma was 1418, right? 814, 1418, and then is 1114. Number याद कर लेना. 814 for Burkitt's lymphoma, 1418 for follicular lymphoma, now 1114 for mantle cell lymphoma with cyclin D. Okay, जी. Now comes these questions which are very easy. FMG एग्जाम में एक तो इनमें से पूछना ही पूछना होता है, और या तो वो रेडियो रेजिस्टेंट पूछता है, रेडियो सेंसिटिव फेस ऑफ द सेल साइकिल पूछता है. तो मतलब रेडियो सेंसिटिव में तो सेल को मार दिया, मर्डर कर दिया, सेल को मार दिया, सेल का मर्डर कर दिया. So the most radio sensitive phase would be G2M. The radio resistant phase is the synthetic phase where the cell is busy, right, in the synthetic phase. But मार दिया cell को, murder कर दिया, that is the G2M variety. So two very important questions that always are asked. Either of the two, मतलब swap करके पूछता है एक सेशन पे radio resistant phase और radio sensitive. अगर आप radio sensitive याद कर लेते हैं G2M तो दूसरे वाला automatically याद हो जाता है. Then comes the most radiosensitive tumor, which is a diphyseal tumor, Ewing sarcoma, where we have that onion peel appearance present. Most radiosensitive testicular tumor is obviously seminoma. So इसमें गलती नहीं होगी and they're very simple. Most radiosensitive organ करके पूछा, उसने bone marrow नहीं दिया, उसने bone दे दिया और gonads दे दिया, तो आंसर चेंज हो जाएगा, gonads हो जाएगा. राइट, आई मीन इस पे कंट्रोवर्सी यही थी कि सर बोन मैरो बोलना है या मतलब स्टूडेंट्स के हिसाब से कंफ्यूजन था. हमारे माइंड में तो कंफ्यूजन नहीं है, लेकिन एग्जाम में जब प्रेशर होता है तो दैट इज व्हेन दिस कंफ्यूजन कैन कम कि फिर बोन मैरो तो सबसे ज्यादा मतलब फास्टेस्ट डिवाइडिंग सेल्स आर प्रेजेंट इन द बोन मैरो. सो रेडियो सेंसिटिविटी इज बेस्ड ऑन हाउ फास्ट द सेल्स आर डिवाइडिंग. सो इट इज बोन मैरो फॉलोड बाय गोनाड्स. नाउ इफ आई रिमूव द वर्ड मैरो फ्रॉम बोन and I compare bone, तो bone की growth तो limited होती है, then the answer will become gonads in the patient. So I hope this is clear. Again, a easy question to be picked up. The most radiosensitive blood cell is a lymphocyte. क्यों? क्योंकि उसका न्यूक्लियस बहुत बड़ा होता है. Bigger is the nucleus, more will be the susceptibility. जो lymphocyte होता है, उसका जो सेल होता है, जो उसका न्यूक्लियस होता है, that will be covering almost more than 80-90% of the total cell diameter. So considering a lot of DNA, considering a big nucleus, it will be most radiosensitive. You guys have been quiet for a while, तो आप लोग कमेंट कर दो. I'll wait for your comments here at the moment so that at least we are aligned there. Most radio resistant blood cell. Yeah, if bone marrow था फिर तो आंसर bone marrow ही हो जाएगा. If it is bone marrow तो bone marrow ही. Yes, what is the most radio resistant blood cell, guys? Yes, exactly. Spot on answers came up immediately. They'll be lacking a nucleus now, so the most radio resistant blood cell would be platelet. So very easy questions, I think. ये तो गलत होने नहीं चाहिए. और फिर check points पढ़ लेते हैं. Check points for this particular part, that is G1 to S पे check point जो है, and second जो check point होगा वो G2 और M पे है. तो मतलब दो check points की बात कर रहे हैं. So check points for G1 S stage would be P53 and RB gene, and if I do G2M then it is P53, which is called as the guardian of the genome. So P53 तो common ही है. It's just that for this longer phase G1 to S1, that is where the P53 longer distance पे है, तो मतलब दो check point यहाँ पे लगाने की जरूरत पड़ गई. So RB and P53. RB gene is related to which chromosome, guys? RB gene is related to which chromosome, by the way? Yes, P53 is from chromosome 17, and when it comes to RB gene, that would be chromosome number 13. Okay, next is tumor suppressor genes. P53 एक बार revise करना है. The commonest mutated gene in human cancers is P53 mutation. Though I think I have asked this already, but फिर से पूछ लेता हूँ. Breast cancer के लिए most common mutated gene कौन सा होता है? Options हैं BRCA1, BRCA2, P53. Yes, guys. Which of the following is the most common mutation related to breast cancer? Very good. 13q15 came up. Very good. Very good. Yes, for breast cancer, because most of the time जो breast cancer होता है वो sporadic होता है. So the answer would be given as P53. Yes, the answer would be given as P53. और तभी जैसे मैंने डेटा बोला, ओवरऑल द मोस्ट कॉमन म्यूटेटेड जीन इन ह्यूमन कैंसर्स इज P53 म्यूटेशन दैट वुड बी रिलेटेड टू क्रोमोसोम 17, also called as the guardian of the genome, and acts at G1S checkpoint as demonstrated earlier. अब करता क्या है, लाइक इन रिस्पॉन्स टू डीएनए डैमेज दैट वुड इट विल हेल्प यू, इट विल गिव यू टाइम, मतलब बेसिकली 2 मिनट सांस लेने दो वाली बात हो जाती है, इट विल अलाउ डीएनए रिपेयर, एंड अगर डैमेज इरिवर्सिबल है फिर तो अपॉप्टोसिस ही हो जाएगी, बट देन दिस इज गोना बी लाइक दैट चेक पॉइंट विच विल गिव दैट ब्रीदिंग स्पेस फॉर द सेल टू डू अ डीएनए रिपेयर. And if it is irreversibly damaged or inactivated, then there is gonna be problem with development of cancers. And one of the common cancers that is usually associated and is asked is having all of them beginning with B, that is called as Lew-Fermani syndrome. The pattern of inheritance, yeah, familial in only 10 to 20% cases only, like female breast cancer BRCA1, female breast cancer BRCA2, but most common जो है gene involved है, most common mutated gene for sporadic breast cancer is P53 mutation, as somebody commented even in the end. Now coming to Lew-Fermani syndrome, सारे B वाले ट्यूमर्स हैं. It would be breast cancer, brain, bone tumor and blood cancer that would be present. तो ओरिएंटेशन कर लेते हैं, पहले ब्रेन हो गया, फिर ब्रेस्ट का हो गया, फिर हड्डियों का हो गया और फिर ब्लड का भी हो गया. बोन मैरो से रिलेटेड आगे, I did not say bone marrow, I said bone and then I said blood, but then you can remember like this: brain, breast, then bones, हड्डियाँ, and then is the blood cancer that can be present. Blood cancer most of the time that can be seen as acute lymphoblastic leukemia and Lew-Fermani syndrome. The pattern of inheritance of this would be autosomal dominant. And we'll compare this with RB gene, that is for chromosome number 13q14. This was an image based question that was given. बच्चा जो है उसको leukoporia, like there was a unilateral white lesion seen in one eye of the patient, initially looked like a cataract. But then when we did a fundus examination, it showed that there is a tumor which is developing, which is by the name of retinoblastoma. He actually was giving clinical information and then expected you to identify the rosettes. So in this particular slide, the main focus will be how to differentiate Homer-Wright rosettes from that of Flexner-Wintersteiner rosettes. Before I go forwards, just a quick line diagram representing rosettes वाले जो cells होते हैं. I'll just represent the rosette वाला component once again. If you can see कि उसके अंदर पिंक मटेरियल प्रेजेंट होगा, if you can see उसके अंदर में पिंक मटेरियल प्रेजेंट होगा, that is called as neuropil, that would be called as Homer-Wright pseudo rosettes. But अगर अंदर वाला एरिया बिल्कुल क्लियर है, if you are gonna get a clear area in the middle, then it would be a Flexner-Wintersteiner rosette that would be occurring. I highlight the feature once again. If you find emptiness present in the center of it, then it would be called as a Flexner-Wintersteiner rosette. Let me now show you the slide. Yes, the clear sky. You can see the clear sky in the between in the rosettes. So this would be a Flexner-Wintersteiner rosette. Like winter में sky clear होता है. That's how you can remember that. And Homer-Wright pseudo rosettes would be having that pink material in the middle. So very classical, easy slide to be identified. And I think most guys were able to identify this and answer it beautifully. Then is retinoblastoma can be sporadic, it can be familial. अगर familial होगा तो the tumor will be bilateral. And then he also asked about trilateral retinoblastoma, where in future the person can have a tumor of the bone, where you read about Codman triangle and you read about that sunburst appearance, that would be osteosarcoma, and one more pineoblastoma. So trilateral में आपको याद करना retinoblastoma, osteosarcoma and ROP, retinoblastoma, osteosarcoma and pineoblastoma. And even the histopathology slide is what I've already explained to you at this moment for retinoblastoma. RB gene related to chromosome 13 is to 14. The last point in the neoplasia part before we start with the GPath component is Warburg effect. Warburg effect क्या है कि the cancer loves sugar and it hits mitochondrial efficiency. I mean, that is how I can explain it. That cancer को बस एक ही चीज चाहिए, growth. जैसे आजकल कई कंपनीज हैं यूनिकॉर्न्स जो बन जाते हैं ना, लाइक 1000 करोड़ प्लस का टर्नओवर, उसके बाद उनको चाहिए होता है सिर्फ 1 बिलियन, देन 2 बिलियन, 4 बिलियन, लाइक दे हैव टू इंक्रीज देयर ग्रोथ like every year. So for that they just go crazy and they start adopting all kind of wrong kind of tactics, and that results in downfall. Like you can see like Byju's had a fall because they were trying to grow very fast. So everything has an organic phase of growth, and if cancer is something which does not believe in organic growth, वो इन मतलब बहुत तेजी से ग्रो करता है और तेजी से ग्रो में वो उसी आदमी को मार देता है ना. लाइक कैंसर जो है that is like a rakshas which grows in the body and then kills the one who's feeding him. So the cancer also dies with the person also. You see, the point is the cancer also dies with the person. So similarly, like, you know, if the company is growing too fast and the revenue is increasing too fast, one day the CEO or anybody related to the company will die, either of a heart attack or he'll go behind bars because of some unethical practices that would be doing. I mean, these are like couple of, I would say, examples that I want to say for that cancer, which is like कि जिसने खाना खिलाया उसी को मार दिया. Now, why is this weird? The weird part is like glycolysis gives us 2 ATP, oxidative phosphorylation is 36 to 38 ATP, but वो क्या कह रहा है कि मुझे तो बस एक ही चीज चाहिए, एनर्जी देते जाओ, चाहे inefficient energy, because it needs nucleotides, it needs amino acids, it basically needs proteins. So what I'm trying to explain to you at the moment is what you call as Warburg effect. Warburg effect is basically a process where there is a aerobic glycolysis. I mean, after all, कहानी किस चीज की है? कहानी इस बात की है कि उसने ऑप्शंस बना दिए, anaerobic, aerobic glycolysis. It is a aerobic glycolysis. It is a very most inefficient way of energy generation. It is one of the most, हाँ गड़बड़ी वाला. Okay, I get the point. आजकल वो बड़ा चल रहा है, right? So like aerobic glycolysis is basically like when I say the word aerobic glycolysis, it is one of the most inefficient methods of energy, but at the same time it will be helping in tumor growth and proliferation because it will be providing like intermediates for nucleotides, lipids and amino acids. So just wanted to highlight the Warburg effect for the cancer part, and now I think we can move to the subsequent part of the discussion. This is where I talked about the common genes and the common cancers that you guys should be remembering. And now what I will discuss is common things like Shediac-Higashi syndrome. Then I'll talk about how to differentiate it from Job syndrome, how to differentiate it from Dye-George syndrome, because all of them will be having issues related to recurrent pneumonia as a presentation. So I'll move on my subsequent slide. I am liking the comments in the chat, but obviously they are very, very controversial. So I would not like to comment much about them. And today, nowadays, we doctors have to be very, very careful regarding the kind of things that we speak, because you never know what might be caught, and unnecessarily people might go behind bars है ना, खान सर को पकड़ लिया जैसे है ना, कुछ भी हो रहा है भाई. चलो. Fine. I need to change my slide, guys. You need to. Okay, this is slow. Let me use a different way. हाँ जी चलो. चलो जी शुरू करते हैं. Let's focus on some basic things that you guys have to remember. Reversible, irreversible cell injury and couple of facts. So most common cause of standard questions है यार, सभी जगह वही लिखा होता है. Most common cause of cell injury happens to be hypoxia. कमेंट कर दो फटाफट से, चारों क्वेश्चन का आंसर एक साथ कमेंट करो, मैं नहीं बोल रहा. Yes. Anything can happen, man. So you need to be careful. अभी पेपर दे लो पहले. यस हाइपोक्सिया मोस्ट कॉमन, चारों का आंसर एक साथ दे दो ना. हाँ ठीक है. मोस्ट कॉमन कॉज ऑफ हाइपोक्सिया इज इश्कीमिया. मोस्ट सेंसिटिव मुझे तो फनी लग रहा है डिस्कस करते हुए भी. द सेल व्हिच इज मोस्ट सेंसिटिव टू हाइपोक्सिया. यस गाइस, न्यूरॉन्स ना. वेरी गुड. And resistant जो होगा that is gonna be fibroblast obviously. So these are very standard questions which are anyway very well known to you. Neurons die very fast, so that is why the window period for like treatment of ischemic stroke is kept as 4.5 hours. अब मुझसे रहा नहीं जा रहा, तो आप बताओ मुझे विंडो पीरियड फॉर MI जो है, विंडो पीरियड फॉर मैनेजमेंट ऑफ ST एलिवेशन MI विद थ्रोम्बोलाइसिस इज हाउ मेनी आवर्स? जैसे स्ट्रोक के लिए 4.5 आवर्स होता आइडियली. For acute ischemic stroke, it is 4.5 hours because neurons are very vulnerable. वैसे what is the window period of ST elevation MI management? Window period is calculated from the time of onset of symptoms. है ना? Option दूँ? चलो ऑप्शन दे रहा हूँ. 3 hours, 6 hours, 12 hours, 24 hours. 3 hours, 6 hours, 12 hours, 24 hours. अरे वन मत बोलो बेटा, हार्ट तो इज लाइक वही तो पैथो जिससे भी पढ़े हो वो यही तो बताते हैं कि भाई द हार्ट इज लाइक मोर रेजिस्टेंट, टफ। हार्ट नहीं टूटता है, ब्रेन पहले जल्दी वल्नरेबल ब्रेकअप हो जाता है। एग्जैक्टली एग्जैक्टली। ऑप्शंस ओके, 3, 6, 9, 12 hours, वेटिंग फॉर अनदर 10 seconds। 3, 6, 9, 12 hours, 24 भी आ रहा है, चलो ठीक है ओके। बेटा मैंने बताया हुआ है, विंडो पीरियड फॉर एसटी एलिवेशन एमआई मैनेजमेंट इज 12 hours। 12 घंटे के बाद में क्लॉट ऑर्गेनाइज हो जाता है ना, हार्ड हो जाता है, तो दवाइयाँ काम नहीं करती है। मेडिसिन डोंट वर्क आफ्टर 12 hours, सो इट इज लाइक 4.5 hour। दो याद कर लेना, 2 points to be remembered, 4.5 and 12 hours respectively. Heart is more resistant to hypoxia, brain is less resistant to hypoxia. Good. Next we focus on the aspects of reversible cell injury. The word is मार, सेल को मार पड़ रही, तो सेल को मार पड़ेगी तो तीन चीजें होंगी, माइटोकॉन्ड्रियल डिस्फंक्शन, then would be anaerobic glycolysis, and then would be ऑक्सीजन की कमी हो जाएगी, तो सेल्स विल स्विच टू एनारोबिक मोड ऑफ रेस्पिरेशन। कैंसर की बात नहीं कर रहा, वो तो इनएफिशिएंट रेस्पिरेशन था ना, दैट इज एरोबिक ग्लाइकोलाइसिस। दिस इज एनारोबिक बिकॉज देयर वुड बी a decrease in blood supply to the heart or to the brain, so the cells will switch to anaerobic mode of respiration and lactic acid would be produced. मार में माइलिन फिगर्स नहीं आता क्योंकि माइलिन फिगर्स दोनों में मिलते हैं। Myelin figures are concentric lamellations that would be found in both reversible and irreversible cell injury. So it is mitochondrial dysfunction, and then would be anaerobic glycolysis, and then is जो दो होता है ना, एक स्मूथ एंडोप्लाज्मिक रेटिकुलम होता है और एक रफ एंडोप्लाज्मिक। जो स्मूथ होता है वो तो कोलेस्ट्रॉल सिंथेसिस के लिए होता है, रफ एंडोप्लाज्मिक जो होता है प्रोटीन्स के लिए होता है। तो रफ एंडोप्लाज्मिक रेटिकुलम वुड बी डैमेज्ड एंड द प्रोटीन सिंथेसिस विल डिक्रीज and this pump will basically fail. The pump is the sodium potassium pump which is energy dependent, और you very well know कैसे काम करता है। I mean it will send sodium outside, free sodium outside, and it will be sending potassium inside. The pump will basically be dependent on ATP and the pump will fail, so sodium बाहर जा नहीं पाएगा। Like if I put a cross over it, I can say sodium cannot go outside. If sodium will remain inside, it will draw water, and that water will then contribute to hydropic swelling developing in this patient. So one of the early manifestations developing would be hydropic swelling, क्योंकि सोडियम बाहर जा नहीं पाएगा, पोटेशियम अंदर आ नहीं पाएगा, तो सोडियम will basically draw in water. So hydropic swelling would occur in a patient along with mitochondrial dysfunction, then is anaerobic glycolysis and rough endoplasmic reticulum being damaged. And now let's compare this with the irreversible cell injury. One of the highlights that they love to ask is this word, flocculent densities. माइटोकॉन्ड्रिया में तो डैमेज है ही है, बट नाउ देयर वुड बी अ फॉर्मेशन ऑफ फ्लॉक्युलेंट डेंसिटीज एंड देन आर न्यूक्लियर चेंजेस दैट वुड बी अकरिंग। ये जो माइटोकॉन्ड्रिया इज द पावर हाउस ऑफ द सेल, so if you are having like amorphous densities in the mitochondria, the ATP production is deep down in the shed, and if ATP production is deep down zero, then the cells would suffer from irreversible injury and the nuclear changes would also be happening. Now nuclear changes can be remembered as whichever way you are okay with. Like PC is Priyanka Chopra, so P pyknosis is condensation, P and the C component to be remembered, Priyanka Chopra. And then X, I mean whenever you are dealing with X, you're like, you know, sometimes if the breakup was unpleasant, then your mind will literally explode and fragment, right? So कार्योरेक्सिस में क्या होगा कि X का मतलब एक्सप्लोजन हो गया, माइंड का गुस्सा आ गया कि अरे यार ब्रेकअप हो गया था, so explosion will cause nuclear fragmentation to happen, and then would be lysis. Obviously that is understandable, cariolysis में तो issue नहीं होगा, that is a nuclear destruction. But then PC and then X are the words which can be used to remember. First is the nucleus will become more tight, like condensation of the nucleus, so it's more basophilic. Then would be the explosion, fragmentation, and then it will ultimately go destruction. So these would be the changes that would be very hallmark of irreversible cell injury in a patient. Irreversible cell injury that would be happening. एंड निमोनिक्स याद नहीं रहते हैं तो निमोनिक्स से मत करना, लॉजिक से करना। उसकी ये ऐसे फोटो बना के दे देगा और आपको एनालाइज करना होगा। तो पहले देखना कि न्यूक्लियस का जो साइज है वो छोटा हो गया, दैट इज कॉन्डेंसेशन, पीसी। उसके बाद में एक्स का एक्सप्लोजन हो गया, दैट इज फ्रैगमेंटेशन, एंड देन द न्यूक्लियस विल डिसअपीयर इन द इरिवर्सिबल सेल इंजरी, एंड दैट इज व्हेन यू विल स्टार्ट गेटिंग दोस गोस्ट सेल्स ना। You read now, coagulative necrosis occurs in myocardial infarction. You get those ghost cells which are having that preserved architecture, but the nucleus part of that is basically changing. So at this moment, you just need to remember the basic points of the movement so that you can get the pointers right. So let's do a quick summary for this. For reversible cell injury, it is that mitochondrial dysfunction. Then is myelin figures दोनों में होते हैं, so that's not a discriminatory fact. Then would be hydropic swelling and damage to the rough endoplasmic reticulum. For the irreversible part, it is mitochondrial flocculant densities, amorphous densities, flocculant densities, whatever. And then is that piconosis, exclusion, that is choriorrhexis, followed by choriolysis, that would be happening in the patient. So once we are sorted with this reversible and irreversible, then we'll focus on the types of necrosis that we come across. ये बड़ी कॉमन सी स्लाइड है, इसमें आई होप यू कैन पिक अप कि कुछ एरिया जो है ज्यादा पिंक है एज कम्पेयर टू द रिमेनिंग वन. So that more pink wala area is the damaged area. It is not the less pink wala area. It is the more pink wala area that is relatively more damaged. And you can also notice कि इनके अंदर के न्यूक्लियस गायब हैं और rather fragmented न्यूक्लियस दिखाई दे रहे हैं. जैसे नॉर्मल देखोगे तो न्यूक्लियस will be inside. This is normal nucleus. Like let me use a yellow marker. This is the normal nucleus. This is the normal nucleus. All of them, these are cardiac myocytes which are having normal nucleus inside. But if you cast a glance at these areas, इनमें न्यूक्लियस है ही नहीं, वो डिस्ट्रॉय हो गया. पहले पेंकनोसिस हो गया था, फिर कार्डियोरेक्सिस हो गया था, फिर कार्डियोलाइसिस हो गया था. So with the arrows I have shown normal, with the tick marks I have shown abnormal, and also I have shown कि इनका जो कलर है वो ज्यादा pinkish appear हो रहा है. So that appearance that is present in this particular case would be yes a contraction band necrosis. Exactly, the cytoplasm is more pink due to protein desaturation and the loss of basophilic nucleus that is present, and these findings would be indicative of presence of coagulative necrosis. तो उसमें तो कोई दिक्कत नहीं है. I mean, like all of you know, वो तो पैथो में से like you guys are very very good at that coagulative necrosis part. What I wanted to bring to your attention is one, this contraction band necrosis that is happening in the heart of the patient. It appears relatively more pink, and obviously this would be present in solid organs with ghost cells being present with preserved tissue architecture. So the first one is done. Then for brain, obviously, like अगर मैं brain abscess की बात करूँ, when the best example I can mention is patient is having a brain abscess. Brain abscess की भी जो location होती है वो vary कर जाती है depending on like where the source of infection is coming from. Because जो brain abscess CSOM की वजह से होता है, chronic suppurative otitis media की वजह से, that would mainly be temporal. But usually in case of infective endocarditis, if it is going to be like, you know, the infection from the heart vegetations, then the location of the brain abscess can vary. Most of the time it would be located in the parietal lobe, which is one of the main lobes supplied by the middle cerebral artery of the patient, and there would be presence of liquefactive necrosis. Brain abscess can easily be identified on a CT because there would be a presence of a concentric round lesion with the air fluid level, where they would be like pus settled at the bottom, and in pathology we obviously call it a liquefactive necrosis. That is mainly in the central nervous tissue because it would be having presence of autolytic enzymes, so pretty easy and I mean easy to identify. And brain abscess will also be having presence of vasogenic cerebral edema. Brain abscess will also be having is vasogenic cerebral edema, so because of that, like the headache and the seizures part in the patient can also be explained. What I've shown in gray can be visible only on giving a contrast, that is like a gadolinium contrast. So this is a symbolic representation to show the very very significant cerebral edema that can be demonstrated in case they give you a contrast based MRI for a brain abscess. Then is that very classical caseous necrosis where they'll give you a specimen of the lung with a cheesy material in the middle, and you can notice, I mean, there's that pinkish material in the middle for the caseous necrosis. That's obviously a feature of TB, but apart from TB, they'll also ask you about fungal infections which can be contributing to the same. So for caseous necrosis, I mean, what are those fungal infections that would be causing it? That is blastomycosis, coccidioidomycosis, and then histoplasmosis, to name a few, which are those classical ones. For blastomycosis, most of the time the image might also give you gomoremethamine stain. And in gomoremethamine stain for blastomycosis, you will notice that the cysts will be exhibiting budding of the cysts. And for coccidioidomycosis, you might be having that pilot wheel appearance of the cysts. For blastomycosis, coccidioidomycosis, histoplasmosis, I mean, they can give slides also with gomoremethamine. And these are conditions which will be contributing to development of caseous necrosis. I mean, pretty straightforward. TB, then blastomycosis, coccidion, histoplasmosis. Now we'll talk about like fat necrosis. Two situations. One is pancreatitis, and second is breast, the trauma component. Child was playing with the mother, and the head of the child hit against the mother's breast. That can result in like a solid lump in the breast, but can be easily differentiated from any kind of a tumor. So
fatty acid and calcium deposition would be happening. Okay, yeah, histoplasmosis, exactly. Histoplasmosis is what you read as Cave's disease. You also read it about as Darling's disease. Clinically differentiate, yeah, absolutely yes, easy to differentiate, sir. And the clinical manifestations would be pretty, totally different. Histoplasmosis would be more common in immunocompromised patients, no? And then most of the time the manifestations would be present bilaterally, and then the guy might be like, the occupational history has to be taken into consideration. Fat necrosis done, then we talk about fibrinoid necrosis, where the blood vessels would be having this eosinophilic pink material in a concentric fashion, and all these conditions which are having fibrinoid necrosis would be having these three alphabets: SLE, rheumatic heart disease, polyarthritis nodosa, and then hypertension. Three alphabets for the fibrinoid necrosis component. Yeah, the trauma part is there. Okay, fine. Next is regarding apoptosis. Again, a very easy topic for you guys. They usually give up an image where you can notice the stepladder pattern for apoptosis. He has asked not the stepladder pattern. He has asked कि ये क्यों होता है. So let's just quickly read regarding the stepladder pattern for apoptosis as well. Yes, guys. Programmed cell death caused by caspases. Caspases की full form बोल देना. Caspases की full form बोल देना. C would be for cystine residues. Yeah, pancreas can be having both liquid as well as fat necrosis. Exactly, both can be possible. That's why, Chauhan, you asked that question. That can be because I can explain pseudo-pancreatic cyst. है ना, जैसे acute pancreatitis की complication होती है pseudo-pancreatic cyst. That pseudo-pancreatic cyst is the liquefactive necrosis that is happening in the patient. Pseudo-pancreatic cyst will present as a epigastric lump. So that is a liquefactive necrosis that is happening. या सिस्टाइन रेजिड्यूज एंड ASP से होता है एस्पैरेटेट. C से हो गया सिस्टाइन, ASP से हो गया एस्पैरेटेट. दैट सिस्टाइन रेजिड्यूज दैट क्लीव एस्पैरेटिक एसिड इज द फुल फॉर्म ऑफ कैस्पेस. और ये करता क्या है, तो ये एक्टिवेट करता है DNA एस को. सो उसने ये पूछा था कि स्टेपलैडर पैटर्न क्यों होता है, तो आपका आंसर है कैस्पेस दैट एक्टिवेट DNA एस. और बस इतना अगर याद हो तो बाकी तो समझ में आ जाएगा कि DNA एस क्या करेगा, वो जो न्यूक्लियोसोम्स है या DNA को कट करना शुरू कर देगा 180 to 200 बेस पेयर्स, एंड दैट इज व्हाई इट अपीयर्स इन ऑर्गेनाइज्ड पैटर्न एट द मोमेंट. So the statement to be remembered would be caspases में C से हो गया cysteine as cleaving aspartic acid, and that activates DNase which will break the DNA via nucleosomes into a stepladder pattern. Related MCQ, stepladder pattern on a X-ray abdomen. Stepladder pattern on a X-ray abdomen. Quick answers please. अगले 10 सेकंड में कमेंट कर देना. Yes, guys, waiting for your answers there. Stepladder pattern on X-ray abdomen would be a feature of. Option 2. और the option की तो जरूरत होनी नहीं चाहिए ना. Yes, that would be a small bowel obstruction, SBO. Very good. It is interstitial obstruction. It would be an SBO. So 2 times is where we read the stepladder pattern. For apoptosis, first aspect is caspase that is activating DNase. Caspase full form was discussed. Now our 2 examples physiological. One physiological example is endometrial shedding during menses. Second is like when the baby will develop, like our fingers, all of them are separate. The hand forms initially and then the fingers become separated. But then in some conditions you might have read about syndactyly. Syndactyly is where all the fingers will be joined to each other. That's because of the apoptosis process was not perfectly happening. So these were 2 examples of physiological ones. And then the pathological ones are Councilman bodies and civet bodies. Councilman bodies, also written as apoptotic bodies, are seen with hepatitis B and C. Please remember, दोनों के साथ मिलता है. Like what I got comments was कि सर मैम ने बोला था कि वो हेपेटाइटिस सी के साथ होता है. ऐसा नहीं है, वो दोनों के साथ मिलता है. मेन डिफरेंशिएटिंग फीचर है कि अगर वो बोलता है ग्राउंड ग्लास अपीयरेंस ऑफ हेपेटोसाइट्स और साथ में बोलता है काउंसलमेंट बॉडीज, तो आंसर हेपेटाइटिस बी होता है. और अगर वो काउंसलमेंट बॉडीज अलोन को फोकस कर रहा होता है पैथो में, देन इट इज हेपेटाइटिस सी. आई रिपीट द डेटा अगेन. इफ ही सेज इन अ क्वेश्चन ground glass appearance of hepatocytes and Councilman bodies, then your answer is hepatitis B from the pathological information given. रियलिटी में तो यार ये तो एकेडमिक हो गया ना. रियलिटी में तो आप सीरोलॉजिकल टेस्टिंग करते हो. नोबडी गोज इनटू दीस पैथोलॉजिकल वेज फॉर आइडेंटिफाइंग. But just for the heck of it, because they put up questions in pathology for that, if it is lone consonant bodies, that is C, that does not mean कि consonant body सिर्फ C में मिलती है. What my point? Combination है, single है, lone consonant body लिखा है, that does not mean कि वो diagnostic of hepatitis C है. It is just that वो दोनों relative data. Then is civet bodies that would be seen in lichen planus, that purple polygonal plaques which are present. The highlight of this condition would be that white marks in a crisscross striations which are present over it. The crisscross striations that are present over this would be called as Wickham striae. So next is the mechanism of apoptosis. How to remember it? भाई सेल तो कह रहा है आके मुझे खा लो, बट वो पॉइंट नंबर 4 तक पहुंचने के लिए व्हाट आर द स्टेप्स दैट आर इन्वॉल्व्ड. सो इट इज एक्सट्रिंसिक, इंट्रिंसिक एंड एग्जीक्यूशनल फेसेस. तो लेट्स वर्क आउट. फर्स्ट एंड फॉरमोस्ट, द caspases which are involved in initiation, that is the extrinsic pathway. Extrinsic may it is the even numbers which are to be remembered via CD95, that is gonna be 8 and 10, right? 8 and 10, and the intrinsic pathway is gonna be the 9 variety. तो पहले तो आपको डिफरेंस याद रखना ना. The extrinsic pathway is gonna be the one which is gonna be like CD95, 8 and 10. And on the other hand, if he mentions intrinsic, then it is 9. याद कैसे करना है? Extrinsic pathway, it's gonna be like even number वाला. Intrinsic is 9. Execution में याद करना, जैसे execution is a function of James Bond, 007. So it is 367. So I hope you were at least able to get the numbers right. I'll move the slide. Extrinsic step is via CD95. नहीं याद हो तो लिख लेना. That would be caspases के numbers लिख रहा हूँ. That would be 8 and 10. For the intrinsic pathway, the caspase would be 9. Execution, as I said, James Bond का काम is 007. So that can be used to remember that 3, 6 and the 7 varieties for the caspases that are involved. इनके बाद में अगला स्टेप आता है जो स्टेप नंबर 4 है. दैट इज द मोस्ट इंपॉर्टेंट स्टेप, द ईट मी अप सिग्नल, जिसमें फ्लिपिंग वाला पार्ट होगा. या आई मीन देयर डिफरेंट वेज टू रिमेंबर दैट, बट दैट एक्सट्रिंसिक, इंट्रिंसिक एंड देन द एग्जीक्यूशनल फेस इज द वन टू बी रिमेंबर्ड. Right. So what is the main step? That eat me signal क्या होता है? That is called as ephrocytosis. This is the point जो कि सभी याद करते नहीं है apoptosis में. That is या मिस हो जाता है, मतलब याद तो करते होंगे, मिस हो जाता है. Ephrocytosis. This is the main thing which will make the macrophage consume the cell. And what is ephrocytosis? So आपको याद करना है flipping of phosphatidylserine on the cell membrane. So कैस्पेसिस तो सब याद करते हैं, बट जो अगला वाला स्टेप है वो सबसे क्रिटिकल स्टेप है एज फार एज एपोप्टोसिस इज कंसर्न्ड. दैट इज ephrocytosis. That would be a eat me signal, and then the cell would be obviously like the programmed cell death would be happening. Now are those questions which will talk about pro apoptosis and anti apoptosis factors. So नाम उनके याद करने, तो थोड़े मैंने जैसे राक्षस बना दिए, and then I've created some gods, and like the god will obviously be like promoting survival, and the so-called rakshas or the bad guys are gonna contribute to doing bakwas. Bakwas is Bach, Bax and BCL excess. What they do is they punch a hole in the mitochondrial outer membrane. और अगर mitochondrial outer membrane damage हो जाती है तो water will go inside and the cell will basically be destroyed. So bakwas वाला Bach and Bax, they all look the same. The bad guys, they all cause damage to the mitochondrial outer membrane. But then who are the survival promoters? All of them will lower the apoptosis, and the good thing about lowering the apoptosis component is that सब में LL alphabet आता है, that is BCL2. BCL की फुल फॉर्म पूछी थी, B cell leukemia, MCL2, BCL-XL दोनों में आ रहा है. एक है BCL-XX और एक है BCL-XL. तो आपको एक को याद करना है which is BCL-XL, जिसमें अगेन L आ रहा है. How to remember is that it would be helping in lowering of apoptosis. So that bakwas wala, Bach and BCL excess, they contribute to increased chances of apoptosis. They are the foot soldiers who are being controlled by general. अब वो जनरल्स का नाम क्या है? दो, जैसे पाकिस्तान में जनरल थे ना, एक जनरल बाजवा था और एक आसिफ मुनीर था. बाजवा को तो अभी मरवा दिया उन्होंने, राइट? तो वैसे ही दो बैड जनरल्स थे. तो बैड जनरल्स का नाम क्या? बैड एंड पूमा, राइट? ऐसे टू जनरल्स, बाजवा एंड आसिम मुनीर. दो एक मयान में दो तलवारें नहीं रह सकती, तो एक को मरवा दिया, कह रहे साबुन पे फिसल गया और बाथरूम पे उसकी डेथ हो गई. सो दैट वे द जनरल्स आर बैड एंड प्यूमा, एंड देन इज द फुट सोल्जर्स व्हिच आर डूइंग बकवास, बैक्स एंड बीसीएल एक्सेस. I mean, that's my way of remembering it. You have a different way. I mean, I'm okay with it. But then what are the ones which will be lowering the apoptosis? The lowering वाले जो component होंगे, long life वाले, हाँ जी, exactly, good comment there. That is BCL2, MCL2 और BSL-XL. फिर उसने पूछा था P53 काम कैसे करता है, P53 जो है वो करता कैसे है, मतलब जब P53 म्यूटेशन आ जाती है तो P53 म्यूटेशन की वजह से तो कैंसर हो जाता है, तो वो लॉन्जेविटी वाला BCL2 को कम कर देता है और बाक्स को बढ़ा देता है। इसके कॉम्बिनेशन बना दिए, बोथ मोर बैक्स एंड BCL मोर, बैक्स एंड BCL लेस, वन मोर वन लेस, ऐसे करके कॉम्बिनेशंस बनाए थे। सो द कॉम्बिनेशन टू बी रिमेंबर्ड वुड बी P53 म्यूटेशन causes बैक्स का the promoter of apoptosis to increase and the longevity wala component to decrease, which is why there would be like excess bakwas is what you can remember, that can help you remember this information. Then are must know facts about apoptosis. Molecular marker of apoptosis CD95. This would be belonging to the extrinsic step. If he just says molecular marker, then the answer is CD95. If he says the word marker of apoptosis, word dekh lena. If he says the word molecular marker of apoptosis, CD95. If he says marker of apoptosis, that would be annexin B. Then are the microscopic findings where you can notice these pink bodies present in the middle. These pink bodies are the normal cells that had died. So cell shrinkage and the cell will become eosinophilic. कैंसर में क्या होता है, सेल बिकम्स मोर बेसोफिलिक, द न्यूक्लियस बिकम्स बिगर. व्हेनेवर देयर इज अ कैंसर, हाउ डज अ पैथोलॉजिस्ट नो इट इज अ कैंसर? इंटेंस बेसोफिलिया, change in the nuclear cytoplasmic ratio. But whenever it is apoptosis, it's gonna be a cell shrinkage, cytoplasm is more eosinophilic, and yeah, nuclear chromatin condensation would be present. Then he is asked about the stain which is used to demonstrate the apoptosis process, that is called as tunnel. Tunnel की full form पूछी हुई है, that would be terminal deoxynucleotide transferase. For the gel electrophoresis तो कोई दिक्कत नहीं है, but the stain part which is to be remembered is tunnel. फिर से प्रैक्टिस कर रहे हैं, marker, molecular marker, then is gonna be the stain which is responsible. Gel electrophoresis you will answer, right? It is marker, molecular marker, and the stain component to be remembered. The first question was molecular marker CD95. Then was a marker, that was annexin B. And the stain is tunnel, that is terminal deoxynucleotide transferase stain, along with that histopathological finding that would be present. Next we'll talk about a question which was asked in your exam, that is netosis. Netosis again is a super important concept. आप सबने स्पाइडरमैन को देखा है. स्पाइडरमैन क्या करता है, whenever he is dealing with the bad guys, first में तो he'll try to punch, he'll try to defend, he'll try to protect himself. But if the bad guy is trying to trouble him too much, then he does like this now, and that suddenly that web will come out. So imagine neutrophil is a Spider-Man, and now the neutrophil has to fight against the bad guys. So like it is fighting is the COVID virus, and COVID virus was a totally new virus. So neutrophil was not being able to kill it. So what will it do? It will try to spin a web. That extracellular trapping that I'm talking about, which will basically trap the harmful microbe and then present it to the security system, is what is called as netosis. Two important aspects to be remembered for netosis would be COVID-19. In COVID-19, we were having cytokine storm. In COVID-19, we were having cytokine storm. That is because यहाँ पे जो न्यूट्रोफिल का एक्स्ट्रासेलुलर ट्रैप था वही प्लेटलेट्स को एक्टिवेट कर रहा था. I'll say that again. निकला क्या? Nuclear chromatin containing DNA, histones and granules are released extracellularly. That is good news. You are trying to catch the bad guy. But what will it do? It will activate the platelets, and therefore there was a development of microthrombi. Like COVID के टाइम पे क्या हो रहा था कि जब neutrophil was trying to destroy the bad guys, so by releasing this net of extracellular DNA, stones and granules, it was activating the platelets also, and there was microthrombi that were being formed, and these microthrombi were then contributing to multi-organ failure in patients. So patients की जो death हो रही थी वो pneumonia से नहीं हो रही थी. It was microthrombi in the lungs, microthrombi in the brain, microthrombi in the kidney, which is why I use the word cytokine storm to describe the process of netosis. So total मिला के 3 बारी हम netosis process के बारे में पढ़ते हैं. Diseases where netosis is seen. Systemic lupus erythematosus. This was the old FMGE exam question. Prior to this, जब COVID चल रहा था, then in our FMGE exam they had asked about COVID and Miss C. Miss C की full form बोल देना. And the third answer I had from somebody was a very very good answer. That is gonna be DIC. That is disseminated intravascular. Disseminated intravascular coagulation. See, it was a foreign antigen. Body did not know what it is dealing with, so neutrophils were going haywire, right? So that is what was causing the problem. Obviously, it does not act against the viruses. Sepsis is the trigger for DIC. Sir, the technical answer will not be sepsis. The technical answer for where NETosis is seen will not be sepsis. It is sepsis-induced disseminated intravascular coagulation. MIC क्या होता है? MIS क्या होता है? Yes, it is trying to cater to the sandman. Okay, yes guys, waiting for your answer. Miss C. Multiple inflammatory syndrome that is seen in children. Is multiple inflammatory syndrome. It was having features identical to that of Kawasaki. Not exactly Kawasaki, but was having features identical to that of Kawasaki. But anyway, keeping things simple. NETosis जो है, that is like extracellular traps by neutrophils. It is a release of DNA, histones, and granule proteins sent out. The attempt is to trap the bacteria. But the bad thing is that it acts like a trap, or it acts as scaffold for platelet activation. So therefore, platelet activation will contribute to development of microthrombi in multiple circulations. The diseases responsible for this would be the diseases which is responsible for, diseases where NETosis was associated was COVID-19 and MIC. It is a viral infection, but the point is, it is a viral infection. NETosis is not effective. That is why deaths were happening in COVID. Soon we realized that we have better strategies. Now we developed antivirals against it. So I want to highlight this fact that NETosis is not affected against the viruses, but it was causing the deaths in COVID-19. That is because of the microthrombi formation. So I hope it is clear that NETosis will not kill the COVID virus. That is why COVID was killing us now. If NETosis was effective, then the infection would have been controlled. Okay. Next, we'll talk about two basic things, hyperplasia and hypertrophy. That's pretty straightforward, so I don't need to explain that. Next is metaplasia. आप लोगों के लिए question है, which is the commonest type of metaplasia? Options are columnar to squamous and squamous to columnar. Which is the commonest type of metaplasia? Squamous to columnar, columnar. फटाफट से कमेंट करो यार, बार बार नहीं बुलवाना. Yes, squamous to columnar and columnar to squamous for metaplasia. Waiting. The most common variety is not squamous to columnar. The most common one is columnar to squamous. The most common variety of metaplasia is columnar to squamous. Smoking is more common than Barrett's esophagus. Guys, it is not squamous to columnar. That squamous to columnar is for Barrett's esophagus. I agree to that. But the question was, what is the most common type of metaplasia? The answer is columnar to squamous. क्योंकि सिगरेट पिएगा ना, तो सिगरेट पिएगा तो columnar से squamous वाला manifestation होता है. तो squamous to columnar is gonna be answered as metaplasia. Yes. Okay, fine. Then is Barrett's esophagus, जिसमें squamous to columnar होता है. Obviously उसमें हम stain क्या यूज करते हैं, म्यूसिन्स, मतलब देखने गॉबलेट सेल्स आ जाएंगे. तो गॉबलेट सेल्स को नॉर्मली तो लाइक esophagus का जो वॉल होता है वो squamous होता है. So here it would be columnar, that would be present, that would be Alcian blue, and that pre-malignant condition will increase the risk of development of adenocarcinoma. The most common cancer of the esophagus is squamous cell cancer. It is common in middle 1/3. But if it is Barrett's esophagus, then there would be increased risk of development of this cancer. Everybody to comment, what is the investigation choice for Barrett's esophagus, by the way? Best investigation for Barrett's. Waiting for your answers here. Investigation choice for diagnosis of Barrett's esophagus, guys. मुश्किल सवाल थोड़ी ना भाई. Upper G endoscopy, and you will be doing is a punch biopsy. Yeah, endoscopic biopsy would be done in the patient. So it is upper G endoscopy with a punch biopsy, and subsequently the report will let us know whether we need to go ahead with surgery in this particular patient or not. And Barrett's esophagus is related to GERD, that is gastroesophageal reflux disease. Yes, investigation for choice of GERD is again a upper G endoscopy. The gold standard is pH monitoring. Question for everybody, a pH of the esophagus should be less than how much for how many minutes to call it GERD? GERD की बात हो रही है ना? Yes. Yes. It would be having the tongue-like projections into the esophagus. Stomach mucosa having tongue-like projections into the esophagus. Yeah, 24-hour pH monitoring would be done. Esophageal pH would be less than how much? Yeah. pH less than how much for how many hours? pH less than 4 for more than 4 hours per day would be suggestive of presence of GERD in a patient. So there are two types of metaplasia that I've described. Next जो metaplasia होता है, that is seen after a possible fracture. Like this kid was doing skating and he fell down and there was a fracture of the lateral epicondyle. Lateral epicondyle fracture की वजह से the fragment got displaced. So the parents took the doctor to a पहलवान, like जैसे पहलवान, and he did a massage. So if you do a massage over the fracture site, then it can result in development of a mesenchymal metaplasia. That would be a myositis ossificans, which would be a solid lump that would be formed over this particular area of the fracture site, which will usually be explaining the development of malunion that can be seen in a patient. pH of less than 4 for more than 4 hours per day is GERD. The next aspect I was describing was कि एक लड़का बच्चा स्केटिंग कर रहा था, he fell down. उसका लैटरल एपिकॉन्डाइल का फ्रैक्चर हो गया, मसाज किया साइड की इंजरी के ऊपर में तेल वगैरह लगा के, तो उसकी वजह से दे कैन बी हार्ड लंप दैट वुड बी डेवलपिंग आफ्टर 2-3 months at the site of the injury. That is what is called as myositis ossificans, and that would be a mesenchymal metaplasia that would be happening in a patient called as myositis ossificans. So 3 examples: squamous to columnar, columnar to squamous, and then is going to be mesenchymal. As I highlighted, the commonest one is the columnar to the squamous one. Intracellular pigments, we can just rush through in the next 1 minute. Melanin would be M only, that is Mason, Fontana and small stain, and the IHC for melanoma would be human melanoma, HMB45 and S100. हेमोसिड्रिन तो खैर ये तो तुम्हें नींद में जागते हुए भी, नींद में से जगा के भी पूछा जाए तो Prussian blue और pearl stain. For copper it is rubianic acid and rhodanine. It is not rhodamine. Rhodamine is for TB, it is rhodanine, and rubianic acid for copper estimation. And one universal question that always comes is, what is the investigation choice for Wilson disease? Then your answer would be liver biopsy. Please don't answer PCR for ATP7. Don't answer ATP7B gene PCR. The traditional answer given in books would be always liver biopsy with estimation of hepatic copper content, though we do have genetic testing available, but the traditional answer given in all books would be liver biopsy with estimation of hepatic copper content. That would be the main investigation that would be done for diagnosis of Wilson disease. Help me out with the chelator of choice and help me out with the drug of choice for maintenance in Wilson disease, and we can move on to our subsequent data. Quick answers please. What is the preferred chelator in Wilson and what is the preferred maintenance drug in Wilson? लिवर बायोप्सी हो गया, मेंटेनेंस का ड्रग बताइए, चिलेटर बताइए. Yes guys. The preferred maintenance drug would be zinc acetate. Yes, zinc acetate is the maintenance drug, and the chelator would be given as trientine. Trientine, if it is not in the options, then the second best answer in the question would be by the name of D-penicillamine. वो डिफ्रॉक्सामिन वगैरह तो आयरन चिलेटर्स होता है, चिलेटर्स की बात नहीं करनी, तो आयरन चिलेटर्स है ना. चलो आपने बोल ही दिया तो मुझे बता दो, प्राइमरी हेमोक्रोमेटोसिस है किसी पेशेंट को, विच जीन ऑन विच क्रोमोसोम? Because we were talking about hemosiderin hemochromatosis, which gene on which chromosome is responsible for primary hemochromatosis? Very good. Trientine is a good answer. Yes. For primary hemochromatosis, what is the gene? तो gene का नाम है HFE gene. HFE gene कौन से क्रोमोसोम पे होता है? तो 6 पे होता है. और कौन से प्रोटीन की फंक्शनिंग को अफेक्ट करता है? तो हेप्सिडिन. It is the hepcidin protein malfunction that will happen. Hepcidin जो होता है regulator of iron absorption होता है. Now the absorption will be more. Hepcidin is that master control. Every gene will be affecting the functioning of the proteins. So gene का नाम है HFE gene, और protein जो affected होता है that is hepcidin. Hepcidin is responsible for controlling the release of controlling the absorption of iron. वाया फेरोपोर्टिन एंड DMT1 ट्रांसपोर्टर इन द स्मॉल इंटेस्टाइन। लेकिन अगर यहाँ पे जीन का डिफेक्ट है तो हेप्सिडिन का मैल फंक्शन होगा एंड देयर इज लाइक मोर एब्जॉर्प्शन ऑफ आयरन, it is increased absorption of iron which will contribute to like bronze diabetes in a patient as well. Okay, so that was about pigments. Then is that wear and tear pigment that is called as lipofuscin. Lipofuscin is always perinuclear. Lipofuscin is always perinuclear. It will be golden in color. Now obviously I don't have a golden color, so I'm just showing it in yellowish brown or like perinuclear pigment that would be present. And oil, redo and fustin may be used for identification. It's a telltale style of damage by reactive oxygen species. Then would be glycogen. Glycogen would be answered, one for glycogen storage disorders and second for diabetes mellitus and proximal converted tubule. That change was asked even in INI-CET exam. It is called as Armani-Epstein change. Normally तो diabetes में glomerulus में damage होता है, but यहाँ पे जो change आएगा that would be in the proximal tubule of the patient, that is glycogen deposition in the cell wall of the proximal tubule, that is called as Armani-Epstein change. Yeah, Armani-Epstein change, that's for the PCT, proximal converted tubule. Quickly बता देना, what is the most common histopathological finding in diabetic kidney? Options हैं आपके diffuse glomerulosclerosis and second is Kimmel-Stein-Wilson change. Most common histopathological finding in diabetic nephropathy. Option 1 Armani-Epstein, second is diffuse glomerulosclerosis, third is Kimmel-Stein-Wilson. Which of the following is the most common histopathological finding in a diabetic kidney? Yes guys. Okay, I'm getting हाँ जी इसमें most students गलती कर रहे हैं. The most common histopathological finding is not Kimmel-Stein-Wilson, वो characteristic होती है. इसको गलत नहीं करना है पेपर में. दिस इज वन ऑफ द कॉमन मिस्टेक्स द स्टूडेंट्स मेक, क्योंकि Kimmel-Stein-Wilson ना बड़ा कैरेक्टरिस्टिक सा लगता है, सो पीपल टेंड टू मिस अप ऑन दैट, या सब्सिक्वेंटली देयर वाज अ कोर्स करेक्शन एंड पीपल अंडरस्टूड कि क्या आंसर करना होता है. The most common histopathological finding in diabetic nephropathy should always be answered as nodular, should not be answered as nodular. The most common one is diffuse glomerulosclerosis. अगर मैं इसको चेंज कर दूं and अगर मैं इसको चेंज कर दूं characteristic manifestation, then your answer would be given as Kimmel-Stein-Wilson, and Kimmel-Stein-Wilson is also called as nodular glomerulosclerosis. वो एक ही बात है, चाहे आप Kimmel-Stein-Wilson चेंज बोलो, चाहे आप nodular glomerulosclerosis बोलो, they basically mean the same, but the commonest one is diffuse glomerulosclerosis. जो टिब्यूल में चेंज है उसका नाम Armani-Epstein. Then we'll talk about lipids. मेरा जो पेशेंट है उसने टेस्ट कराया था जिसका नाम था फाइब्रोस्कैन. मेरा जो पेशेंट है उसे टेस्ट कराया था जिसका नाम है फाइब्रोस्कैन. डायबिटिक पेशेंट है, उसको मैंने फाइब्रोस्कैन लिखा था. फाइब्रोस्कैन का दूसरा नाम होता है, हाँ, Kimmel-Stein-Wilson का दूसरा नाम है nodular glomerulosclerosis. मोस्ट कॉमन इज डिफ्यूज glomerulosclerosis. मेरा जो पेशेंट है उसने टेस्ट कराया था जिसका नाम है फाइब्रोस्कैन. दैट फाइब्रोस्कैन का दूसरा नाम होता है ट्रांजिएंट इलास्टोग्राफी. दैट विल टेल यू रिगार्डिंग द डेवलपमेंट ऑफ फैटी लिवर इन अ पेशेंट. फैटी लिवर का जो कॉमन कॉज है आजकल इंडिया में वो बेसिकली नॉन, आई मीन इट इज अर्लियर वी वर यूजिंग द वर्ड non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease, now we use the word MASH, that is metabolic dysfunction associated steatotic hepatitis. I'll just write the name here because this you should anyway be knowing. Metabolic dysfunction associated steatohepatitis is the name for non-alcoholic fatty liver disease. This happens to be overall the most common cause of liver cirrhosis nowadays and is also the number one cause for orthoptic liver transplantation. तो क्लिनिकल प्रैक्टिस में तो मैश का जो डायग्नोसिस है वो हम फाइब्रोस्कैन ट्रांजिएंट इलास्टोग्राफी से करते हैं, बट हम लिवर बायोप्सी भी पहले करते थे नॉन इन्वेजिव तरीके से, एंड इट यूज्ड टू शो डिपोजिशन ऑफ ट्राइग्लिसराइड्स इन द हेपेटोसाइट्स जिसको स्टेटियोसिस बोलते हैं. तो आपने मुझे बताना है कि हाउ मच परसेंटेज ऑफ सेल्स, how much percentage of liver cells will be involved and would be having triglyceride deposition. TG का मतलब है triglyceride deposition present in how much percentage of cells, to call it like steatosis or like fatty liver. Options are 5%, 10%, 20%, 80%. Yeah, tigroid appearance. We'll talk about tigroid also. Metachromatic leukodystrophy. Exactly. We'll talk about that MLD also. Smooth specialist, you have spot on there. Yes, guys. how much percentage of liver cells should be involved to call it fatty liver? वो स्टेटोरिया है शैलेश, दैट इज स्टेटोरिया. आप जो 7 ग्राम्स बोल रहे हो ना, दैट इज फॉर स्टेटोरिया कि फैट की जो डिपोजिशन, जो फैट का अमाउंट है वो कितने ग्राम से ज्यादा हो. इट इज फैट मोर देन 7 ग्राम, दैट यू आर कॉलिंग इट एज स्टेटोरिया. हाँ जी हाँ जी, द कट ऑफ इज 5%. अगर 5% से ज्यादा लिवर सेल्स इन्वॉल्व, ग्रेड्स होते हैं ना यार, माइल्ड, मॉडरेट एंड सिवियर. आप में से कई लोग 70-80% भी बोल रहे हो, दैट 70-80% विल कम फॉर दैट सिवियर वैरायटी जहां पे सिरोसिस होने लग जाता है. बट स्टेटोसिस इज व्हेन मोर देन 5% ऑफ द लिवर सेल्स आर इन्वॉल्व्ड बाय ट्राइग्लिसराइड. ये स्टेटमेंट था कि कितना परसेंट सेल्स में क्या चीज प्रेजेंट हो. सो इट इज मोर देन 5% ऑफ सेल्स हैविंग ट्राइग्लिसराइड डिपोजिशन. आई विल रिपीट दैट अगेन. more than 5% of cells having more than 5% of cells having triglyceride deposition is gonna be like more than 5% of cells having triglyceride deposition, not cholesterol, that is fatty liver. Then comes triggered heart appearance. This would be seen with diphtheria, toxin, myocarditis. Diphtheria में जो सबसे commonest cause of death होता है, that is myocarditis, and the second cause is development of choking. तब इसको village में गलघोटू बोलते हैं. गलघोटू means it chokes the patient in laryngotracheal diphtheria. Then other examples are like cholesterolosis, where you also get the strawberry gallbladder, and then the stains are obviously Sudan black B and then oil red O. And to visualize the fat, क्योंकि सुडान नॉर्मली तो वॉश ऑफ हो जाता है. फैट मतलब गोले गोले दिखाई देते हैं ना, फैट इज ऑलवेज वॉश्ड ऑफ. बट इफ द फैट को विजुलाइज करना है, सो देन वी यूज फ्रोजन सेक्शन बायोप्सी, दैट इज क्रायोस्टैट, दैट हेल्प्स यू टू विजुलाइज द फैट. देन फॉर कैल्शियम, द स्टेन वुड बी कॉल्ड एज गोन कोसा. Another one is by the name of alizarin red. So this is just a list of couple of stains that I have mentioned at the moment. Yeah, Dhanush, that 80% is beta cell destruction. That 80% is beta cell destruction that you are thinking of. Okay, fine. So at the moment we have talked about cell injury. Next we'll talk about that vascular events, and we'll talk about inflammation now. And for inflammation, initial event is obviously vasoconstriction, third year of medical school, followed by vasodilation. But then there are a couple of cellular events that we need to study. So vascular events में तो बस इतना ही बोलेगा कि what is the initial event? It is vasoconstriction. But then subsequently are the cellular events for which we read about margination, rolling, role of selectin, then integrin role, and then diapedesis and transmigration. So let us practice that with help of a mnemonic that is by the name of Mrs. Grindkop. Vircho's triad. Okay, so Vircho's triad जो होता है वो तो basically that basically will help you identify increased risk of deep vein thrombosis. I mean, Vircho's triad is a feature that will increase the risk of deep vein thrombosis in a patient and would be contributing to hypercoagulability. अब क्योंकि आपने या हॉलमार्क इज इंक्रीज वैस्कुलर परमेबिलिटी. फाइन. Okay, so you have a different mnemonic, M Radcop. Okay, I have Mrs. Grindcop and you have M Radcop. So I want you to stick to your mnemonic. But before I do that, question for you guys. Vircho's triad will increase the risk of DVT, hypercoagulability, stasis. Vircho's cell आपने बताना. Vircho's node आपने बताना. Yes. Endothelial injury, stasis and hypercoagulability is feature of Vircho's triad, exactly, and that will increase the risk of deep vein thrombosis in a patient. Okay, Vircho's cell would be found in smooth specialist. Your point is well taken. Endothelial injury, stasis, and then hypercoagulability. So I'll just write E. Endothelial injury is there, stasis is there, and increased chances of clot formation is there. E hashtag means endothelial cell injury. Vircho's cell is in TB. Okay, थोड़ा सा मिस कर रहे हो. Vircho's cell, yeah, leprosy. And Vircho's node is Troyer's lymphadenopathy. It is Troyer's sign, no? It is left supraclavicular lymphadenopathy that can be seen with like stomach cancer. Troyer's sign is Vircho's node involvement that would be seen as left supraclavicular lymphadenopathy. So Vircho's वाले हो गए and Vircho's cells is for leprosy. Very good. Okay जी, so whichever mnemonic you are using, आपका वाला mnemonic मुझसे मिस हो गया. M Radcop or Mrs. Grindcop, whichever way. So initial step would be कि cells बाहर की तरफ आ जाएंगे, that is margination. Initially the cells are flowing in the center, now they will try to move towards the periphery, so that is called as margination, after which they will roll and will show a weak addition via selectin. So selectin को अभी पढ़ लेते हैं, that is CD marker और selectin will also be studied. So misses में तो हो गया margination, rolling, and then via selectin it is gonna attach to the endothelial lining. Then in जो होता है grain का, misses grind का in, that is integrin. That integrin is present on the polymorphonuclear cells. This will help the cells ultimately go across to the target, that is the bacteria. Before I talk about diapedesis and transmigration, my question to you is a clinical one here. आपने मुझे एक ऐसा ड्रग बताना है जो कि एंटी इंटीग्रिन मॉलिक्यूल है, एंटी अल्फा 4 इंटीग्रिन मॉलिक्यूल है, एंड दिस एंटीग्रिन मॉलिक्यूल इज यूज्ड इन अ डिजीज बाय द नेम ऑफ मल्टीपल स्क्लेरोसिस. और ये प्रिवेंट करता है कि जो सिक्योरिटी सिस्टम वाले सेल्स है, जो वाइट ब्लड सेल्स है, वो ब्रेन को अटैक ना कर पाए, बिकॉज ऑल ऑफ यू नो दैट मल्टीपल स्क्लेरोसिस इज अ डिसऑर्डर ऑफ डीमाइलिनेशन ऑफ द ब्रेन. इट इज एन एग्जांपल ऑफ टाइप 2 hypersensitivity reaction where the white blood cells will be causing damage to the brain and that will cause demyelination in the brain. So can you tell me an anti integrin 4 molecule which is basically used in multiple sclerosis? Hi guys, I think we are back again. I hope audibility and the visibility is fine, so we can start with okay, fine. So we're good to go, and I'll just wait for the people in my group to join back. A couple of chota mota topics left that we'll cater to at this moment. Okay, so what we discuss next is the cellular events that are related to the process of inflammation. The mnemonic that you guys are using and I'm using are slightly different. I was saying the word Mrs. Grind, and the question that I had put up to you guys initially was like, what is that anti-integrin molecule that you're aware of that is used in multiple sclerosis? Some guys had commented rightly also, the name of the molecule is natalizumab. They love to ask about this anti-alpha 4 integrin molecule used in multiple sclerosis, which basically targets the integrin present on the security system, by which it is able to cross the blood-brain barrier and is subsequently able to cause a damage. So I think we are sorted at this moment for at least the word in on this mnemonic. So I'll say the points once again. The security system, the cell will be going towards the periphery, margination, rolling, then it will attach to the wall of the blood vessel, will help us selectin, and then present on the like there are two words, one is selectin and second is integrin. तो selectin किस पे होता है? तो selectin is present on the endothelial cells, और integrin किस पे होता है? तो वो security system पे होता है. एक को याद करना पड़ेगा, तो integrin के N से याद कर लीजिएगा, that it is related to N मतलब polymorphonuclear cells. Integrin iron is present on the security system. N matlab neutrophils ka component, that is polymorphonuclear cells, and in contrast selectin would be present with respect to the endothelial cells, and then it will be doing something which is very classical, that is diapedesis and transmigration. और ये diapedesis पे question था, the diapedesis is mediated via that is PCAM31. So I'll show you that mnemonic also subsequently, but for Mrs. Greenkop, these are a couple of steps which are remembered to be remembered. Chemostaxis, then is opsonization, and that is phagocytosis. So let's look at each of these terminologies in detail. First, we are focusing on Mrs. Greenkop as a mnemonic to remember the manifestations, because you can say arrange them in the correct order. And once you've done that, then is the individual steps. Once again, if he says from the clinical perspective, what is the antibody against alpha-4 integrin in multiple sclerosis? As I was asking you, the answer would be given as natalizumab. And the second point to be remembered is what is the antibody against alpha-4 beta-7 integrin in Crohn's disease and ulcerative colitis. If somebody had commented, then the answer would be given as vedolizumab. Two very classical monoclonal antibody-based questions. Now we focus on the individual aspects, that is marginations, the cell are going towards the periphery, then is going to be rolling and weak addition via selectin. Selectin is the one that is present from the endothelial cells, that is called as E-selectin as well as P-selectin. Then is addition to the endothelial cells via integrins, that is beta 1 and beta 2, that is the integrin is present on the security system. And after that is going to be diapedesis, which means that there will be transmigration of the cells. How the transmigration will happen is that these security system cells will be producing metalloproteases. The metalloproteases will damage the basement membrane. In fact, it's wrong to say the word damage the basement membrane. I'll say they'll breach the basement membrane to reach to the bad guys, which is the bacteria or the viruses, whichever may be the case may be. At the moment I'm talking about bacteria. So transmigration via PCAM is to be remembered, and the CD marker for that is CD31. So PCAM31 is what I had said initially as an unofficial way of remembering it. This was an FMG exam question कि diapedesis के लिए जो requirement है, that is of PCAM CD31, and what does it do is release diapedesis process में what the cell does is it releases metalloproteases which will breach the basement membrane so that it can reach the bad guys, that is the bacteria. So the movement which is unidirectional is what is called as chemotaxis, and now will be a process called as opsonization. This opsonization will be done by C3b. C3b is what will make the food tasty. Like गोलगप्पे आपने खाए होंगे तो गोलगप्पे आप प्रोटीन खाते हैं तो वो तो tasteless होते हैं, but then if you add some pani puri into it, it tends to become like very like I mean it's literally bursting of flavors in the mouth, as Gordon Ramsay as a chef would be saying, that explosion of sensation in my mouth, as all the I would say the celebrity chefs would be calling. So what is responsible for opsonization are two things. It is immunoglobulin G and C3b. That is what is going to make the organism more tasty to the bacteria. So that organism more tasty to the security system. So it was COP, chemotaxis, then is opsonization, and then is phagocytosis. Now we are going to focus on two core aspects for phagocytosis, that is oxygen dependent killing and oxygen independent killing. And for oxygen independent killing, what you need to remember is that independent पे issue नहीं होता. It is used to kill the parasites. It is used to basically destroy the parasites. Eosinophils are the cells which will be fighting against the parasites. Eosinophils, when we read, is in allergy, and second is for killing the parasites. Any patient who's having like conditions, in fact I can put up as a question to you guys, which parasite causes tropical pulmonary eosinophilia? Eosinophils will help in killing the parasite. So we are a tropical country, तो कौन सी बीमारी में tropical pulmonary eosinophilia मिलता है? और लॉफलर सिंड्रोम के जो केसेस होते हैं उनमें भी आपको eosinophil count elevated मिलेगा. Absolute eosinophil count is increased in asthma and is also increased in patients with tropical pulmonary eosinophilia and Loeffler syndrome, that is oxygen independent killing that we are talking about. So waiting for your answers, condition that causes tropical pulmonary eosinophilia, condition that causes Loeffler syndrome. While I'm waiting for answers, I will write down the data for oxygen dependent, that is NADPH oxidase. This is expressed by FOX gene, and the system would be called as hydrogen peroxide myeloperoxidase as halide system. So we will look at the steps of it. Yes, guys, let me know. Very good. Loeffler syndrome would be caused by hookworm, and the technical name for hookworm will be Encyclostoma duodenale. Loeffler syndrome is caused by hookworm, that is Encyclostoma duodenale. एंड ट्रॉपिकल पल्मरी इस्नोफिलिया इज कॉज्ड बाय, इसका कमेंट किसी ने करा नहीं, आई थिंक पीपल आर जस्ट फिनिशिंग देयर लंच एंड आर जॉइनिंग एट द मोमेंट. दैट वुड बी माइक्रोफिलेरिया. Microfilaria migrating through the lungs, they would contribute to like multiple spots fleeting pulmonary opacities and would also be having an increased absolute eosinophil count. So the body will kill these parasites by oxygen independent killing, that is through liberation of MBP, that is called as major basic protein, by eosinophils in parasitic infestations. But now we will talk about the steps of NADPH oxidase based oxygen dependent killing, where the steps would be: first, oxygen would be converted into superoxide radical. That superoxide radical ke liye it is NADPH that would be responsible. Then subsequently is a gene, then superoxide will be converted into hydrogen peroxide, and then hydrogen peroxide will combine with chloride to form HOCl with help of this enzyme that is called as myeloperoxidase, and this will be one of the most potent bactericidal, this will be the most potent bactericidal agent that is being generated. The steps are oxygen being converted into a superoxide radical, and then यहाँ पर एक और जीन होता है जिसका नाम, एक और एंजाइम होता है जिसका नाम होता है superoxide dismutase. This superoxide dismutase will now be converting the superoxide radical into hydrogen peroxide. तो एक तो ये सीक्वेंस याद रखनी है, पहले NADPH, then is superoxide dismutase, and then is myeloperoxidase. One disease of superoxide dismutase deficiency I can tell you is by the name of amyotrophic lateral sclerosis. क्योंकि अगर superoxide dismutase less होगा, then these free radicals का जो level है, superoxide radical will be in excess, and superoxide radical will cause damage to the neurons of the patient. It will cause damage to the lower motor neuron, it will cause damage to the upper motor neuron, and this disease where superoxide dismutase activity is less, and you had answered very rightly, doctor, that it would be called as amyotrophic lateral sclerosis. So the steps are NADPH first, NADPH oxidase, then is superoxide dismutase, then is myeloperoxidase, so as to form HOCl, which is the one of the most potent bactericidal agent. Then we will also study about a disease जहाँ पर ये काम नहीं करता है, that NADPH oxidase, if it is not working properly, the disease is called as chronic granulomatous disease. So the objective of studying this entire discussion is basically to focus on those common medical disorders. One that is always asked in your exam from GPath component is chronic granulomatous disease versus Shiedek-Higashi syndrome. So what I will do in next point will be, या eyes भी spared होते हैं बेटा, आपने बोला bladder and bowel spared होता है, एक और point है eyes are preserved. Eyes, ocular and bladder and bowel sparing is found in, best example Stephen Hawking का ना, eyes, bladder, bowel is spared in this patient. तो एक eyes वाला point add कर लेना. Now what we will do is we will be talking in comparison of chronic granulomatous disease in comparison with Shiedek-Higashi syndrome. Shiedek-Higashi syndrome will begin with a kid with blonde hair. Like blonde hair वाले दो क्वेश्चन होते हैं कॉमन आपके एग्जाम में. One is gonna be phenylketonuria, but in there the problem will be different. Phenylalanine will not be converted into tyrosine. Tyrosine will not be converted into melanin, so that is why the question will talk about blonde hair. यहाँ पे the presentation will be usually asked to you as oculocutaneous albinism. Oculocutaneous albinism, as the name suggests, albinos या albinism का मतलब है कि इसमें तो melanocyte बन ही नहीं रहे genetic reasons की वजह से. So the patient will be having blonde hair and possibly a blue iris. And in Shiedek-Higashi syndrome, then you need to remember the gene. The gene to be remembered is called as list1 gene, and the list1 gene is on chromosome number 1. First, the examiner will waste your time. How will he waste your time? He will say a child is brought to the hospital, he is having recurrent pneumonia episodes along with delayed milestones. So you might start thinking in terms of Down syndrome also, no? Because the moment I read the first point, delayed milestones, and then I talk about recurrent pneumonia episodes, I will think in terms of possibility of Down syndrome as well. But then the question will say that when the workup of the patient was done, the doctor had ordered a peripheral smear, because obviously any patient who will come to you with recurrent infections, recurrent pneumonia, you will have to do a peripheral smear examination. In the peripheral smear, he will say that there are some coarse granules which are found in the security system, that is coarse granules in the neutrophils, or instead of writing the word neutrophils, he may write the word like polymorphonuclear cells. I mean, ultimately the point is still the same. Whenever you read the statement coarse granules in the neutrophils, that implies that the neutrophil has ingested the organism, but it does not know how to digest it. This third statement will not be given. This is what they expect out of you. The expectation of the examiner is that Shiedek-Higashi syndrome में होता क्या है? The answer would be defective phagolysosomal activity due to defect in microtubule trafficking of lysosomes. पूरा स्टेटमेंट याद रखना है. It is कि उसने बैक्टीरिया को खा तो लिया, पर खाने के बाद में उसको उसके आगे नहीं पता डाइजेशन कैसे करना है. सो डिफेक्ट इन माइक्रोट्यूबुल ट्रैफिकिंग ऑफ लाइसोसोम्स आर आल्सो कॉल्ड एज द सुसाइड बैग्स ऑफ द सेल. So this is where, like, you know, the phagolysosomal activity implies that the bacteria will now to be destroyed, but then the bacteria have been eaten by the security system. The security system does not know what to do about it. And the third clinical manifestation that is asked for this condition is what I already said, that is oculocutaneous albinism. So there are a total of 3 aspects to be remembered. Let us do a quick recap of Shede-Higashi syndrome. One is those general questions where he will just say what is the gene and what is the chromosome. वो तो आसान है. फिर क्लिनिकल क्वेश्चन कैसे होगा? क्लिनिकल क्वेश्चन विल से रिकरेंट निमोनिया, delayed milestones, peripheral smear shows presence of coarse granules in the neutrophils and the patient is having oculocutaneous albinism. So आपको याद करना है OG. OG मतलब you have to remember oculocutaneous albinism and giant granules. दो स्टेटमेंट जो मस्ट हो है इसके लिए OG वाले are oculocutaneous albinism 1 and the second statement to be remembered is giant granules or big granules which are found in the polymorphonuclear cells. अगर आप ये दोनों चीजें पिकअप कर लेते हो क्वेश्चन में, then it will become easier for you and the kid would be having due to oculocutaneous albinism. तो जैसे albinos होते हैं, white eyelashes, white eyebrows, white hair would be present and even like the iris of the patient will not be black or brown like in an Indian population patient. So this would be like easy to identify the Shede-Higashi syndrome component OG, oculocutaneous albinism and giant granules or like coarse granules in the neutrophils, whichever way you want to remember it. And now I will be comparing this topic with the most important part of this particular session, always asked in your exam, that is chronic granulomatous disease. Yes guys, the same condition in which you read regarding nitro blue tetrazolium test. तो उसने दिया कैसे था पहले उसको देखो. He gave 2 slides. फर्स्ट ही गेव 2 स्लाइड्स. तो एक तो नॉर्मल वाली है, जो नॉर्मल स्लाइड्स होती है ना उसमें जो हम स्लाइड यहाँ पे जो हम यूज कर रहे होते हैं नाइट्रो ब्लू टेट्राजोलियम इज बीइंग यूज्ड. तो नाइट्रो ब्लू टेट्राजोलियम विल कॉज सिक्योरिटी सिस्टम के अंदर में ब्लू ग्रेन्यूल्स टू बी प्रेजेंट. सो दिस इज नॉर्मल. जो ब्लू ग्रेन्यूल्स है, देखो प्लीज अप्रिशिएट, ऊपर तो मैंने जो दिखाया था वो तो रूटीन हेमोटॉक्सिलिन इयोसिन था ना, और रूटीन हेमोटॉक्सिलिन इयोसिन में ग्रेन्यूल्स वर एबनॉर्मल, राइट. लेकिन अभी जो मैं बोल रहा हूँ दैट इज नॉर्मल थिंग इनसाइड, दैट इज द किलिंग पावर ऑफ द न्यूट्रोफिल दैट इज बीइंग डेमोन्स्ट्रेटेड. सो इफ दे गिव यू अ स्लाइड which is hemotoxylin eosin or like in fact not hemotoxylin eosin, the routine right stain, no, I mean for hemat it is the right stain that would be used. So right stain में जो RBCs होंगे वो पिंक होंगे, न्यूट्रोफिल्स जो होंगे ब्लू होंगे. तो जो हेमाटोलॉजी वाला कन्वेंशनल स्लाइड है उसका फोटो देगा, हेमाटोलॉजी वाला स्लाइड देगा, देन द ग्रेन्यूल्स आर नॉर्मल. बट इफ ही विल गिव यू सुपरावेटल स्टेन है जिसमें आरबीसीज ग्रीन दिखाई दे रहे हैं, this is the NBT, nitro blue tetrazolium, that I'm talking about. So normally we are getting blue formation granules, but actually chronic granulomatous disease mein what is happening is that the security system is not having the capacity because of deficiency of NADPH oxidase due to FOX gene to be able to generate superoxide radicals. So there would be a pale neutrophils that would be present. I hope you are appreciating the fact. The previous one, the stain was having those granules present, that was abnormal, but here there are 2 slides present. तो उल्टा होता है कि यहाँ पे जो normal वाला है उसमें blue granules in the security system of the NADPH oxidase is being demonstrated. This blue is representing NADPH oxidase. It is missing, and that is why I said the word pale polymorphonuclear cell. Now, once you get that this is due to FOX gene, the next thing to be remembered is superoxide radical and respiratory burst would not be happening. So phagocytosis will be occurring, but the killing part is defective because there is no respiratory burst that is present. The highlight of this condition will be that there would be infection with catalase positive organisms. Catalase positive organisms would be contributing to like, Staph aureus, Serratia, Burkholderia, and then Aspergillus. So all of them will again be contributing to development of pneumonia only. I mean, Staph aureus में जो pneumonia होता है उसमें pneumatoceles होते हैं, and that pneumatoceles can then result in development of a lung abscess in a patient. Similarly, Serratia, Macerae, Burkholderia, there again those nasty bugs which can cause development of pneumonia. Burkholderia cepacia में pink color के colonies बनते हैं. Then there could be fungal like Aspergillus. And what is the screening test for this condition? It is NBT. And then he is asked what is the investigational choice for this condition? That is dihydrorhodamine, which is used for like flow cytometry based DHR test is done. So how to remember the data is Dr. C0. By Dr. C0, first I would like to focus on the core thing that is present here, dihydrorhodamine. DR से मेरा मतलब है यहाँ पे प्रैक्टिस कर लेना मेरे साथ में. What is defective in this condition is obviously NADPH oxidase activity due to FOX gene. वो तो आपको याद है. जो most common question आता है इस पे, he will say the flow cytometry of this particular patient would be showing doctor, that is dihydrorhodamine is the main test for this condition. Then जो C component है, that is to remember the infection with the catalase positive organism. NO में पहले तो NO से याद करना, that NADPH oxidase. NO would mean N का NADPH and O oxidase is the one which is the defect present here, and then not से याद करना है, N को फिर से O की जगह पे B बना लो, NBT, O की जगह पे NBT लिख लो, that is not लिखा था ना, तो NOT, nitro blue tetrazolium test, which was asked as an image based question, that is what I've highlighted. यहाँ पे क्या है, सुपर ऑक्साइड रेडिकल नहीं बन रहा, सुपर ऑक्साइड रेडिकल नहीं बन रहे हैं. लेकिन जो प्रीवियस वाला कंडीशन था उसमें सुपर ऑक्साइड रेडिकल की प्रॉब्लम नहीं है ना, उसमें तो क्या है कि बैक्टीरिया को खा लिया लेकिन उसके बाद में लाइजोसोम, जो फेगोलाइजोसोमल एक्टिविटी होती है वो दोनों में डिफेक्टिव हो जाती है. सो यू विल बी गेटिंग ब्लू ब्लू ग्रेन्यूल्स इन द न्यूट्रोफिल्स. यहाँ पे तो है ही नहीं ना, किलिंग पावर नहीं है. सो देयर इज अ डिफरेंस. एक में एंजाइम का प्रॉब्लम है, इन वन ऑफ देम इट इज अ प्रॉब्लम ऑफ द एंजाइम, and in the second one it is a problem of formation of a lysosomal, I mean the phagolysosomal activity is defective. So दोनों अलग अलग बात होती है. एक है enzyme defect और दूसरा है phagolysosomal activity. Both of them ultimately contribute to recurrent pneumonia. But then if you focus on the two, like Salish, you said what is the difference here? So first difference is physical appearance of the patient. You will have oculocutaneous albinism given in the question. Second, यहाँ पर जो प्रॉब्लम है उसने बैक्टीरिया को खा लिया लेकिन उसके बाद में लाइजोसोम के साथ में जो फेगोलाइसोमल एक्टिविटी डिफेक्टिव है, whereas subsequently it is an enzyme activity that is defective, NADPH. So both are two different aspects which are to be remembered for CGN versus Shiedek-Higashi syndrome. So both of these questions will talk about recurrent pneumonia. In fact, we can do this quick activity at the moment. Anytime we get a question on recurrent pneumonia episodes, anytime if we get a question on recurrent pneumonia episodes, there are certain possibilities which are to be considered. One of them will be, he might say immunoglobulin E levels are elevated in a patient. Then he will say STAT3 mutation, though I'll talk about it subsequently also, but TH17 neutrophilic recruitment is defective. बच्चे में वाला recurrent pneumonia, फिर वो खुद ही बोलेगा कि in this condition there is elevated immunoglobulin E and there is a delayed dentition which is present. In fact, instead of delayed dentition, he'll say that the patient is having like issues with primary dentition, right? So yes guys, can I have answer in this particular case? दूध के जो दांत है ना वो गिर नहीं रहे, retained primary dentition in a patient. So what is the condition that I'm talking about in this condition or in this situation? Then is recurrent pneumonia episodes, and the question will also mention small platelets. Like he will say patient is having recurrent nasal bleed, small platelets are present. Along with that, antibody levels will also be given, like IgE levels can be elevated, but IgA levels in this condition would be less. I think I've given a bit of hint here, small platelets. Then is recurrent pneumonia with peripheral smear showing granules in the neutrophils, along with information regarding oculocutaneous albinism. And the last entry, like NBT, I'm not including because that is pretty a long mnemonic that I've already explained to you. So the first differential that you have to answer here is called as Job syndrome. The second one, where recurrent pneumonia with small platelets would be present, that would be called as Wiskott-Aldrich syndrome. The third one is where peripheral smears in polymorphonuclear cells with oculocutaneous albinism is present, is Shiedek-Higashi syndrome. So I think total of four at least conditions are covered at the moment for remembering the episodes of recurrent infection. Okay. Next, we'll talk about acute phase reactants. The first acute phase reactant would be interleukin 6. They're regulated via big platelets in Bernard-Soulier. That's a good comment there. Okay. I had a lot of people commenting, limited comments, but yeah, the comments that came were very solid. So I hope everybody is aware of all these facts. Okay, Ji. Next is regulation via interleukin 6 is the acute phase reactants. CRP. CRP की full form बोल देना फटाफट से. What does CRP? John keeps baby tooth on the job. Exactly. Yes, guys. What is the full form of CRP? Others are hepcidin, ferritin, and fibrinogen or acute phase reactants. Negative are TAN. T से transferrin हो गया, transcortin हो गया, which is a transport protein for cortisol, transthyretin, and then albumin. Most of the time, negative phase reactant they ask about albumin, which is a negative phase reactant. Whenever damage is there, like the albumin levels will tend to become lesser. Yes, guys, the full form of CRP, please. I mean, obviously it is C reactive protein, but what does C stand for? हाँ हाँ, वो तो ठीक है, इतना तो इंग्लिश सबको आता ही है, सी रिएक्टिव प्रोटीन। उसने पूछा सी क्या स्टैंड करता है, व्हाट डज सी स्टैंड फॉर? सो सी वुड बी स्टैंडिंग फॉर alphabet C would be standing for capsular polysaccharide or pneumococcus. C would be standing for capsular polysaccharide or pneumococcus. R would obviously be reactive and P would be protein. What I was asking was a very baseline question. उसने बोला कि C की full form क्या होती है? So C की full form would be capsular polysaccharide or pneumococcus. Then is hepcidin, ferritin and fibrinogen. Negative phase reactants are transferrin, आयरन ट्रांसपोर्ट, ट्रांसपोर्टिन, कॉर्टिसोल ट्रांसपोर्ट, ट्रांसथायरेट्रिन। जो ट्रांसथायरेट्रिन होता है वो क्या क्या ट्रांसपोर्ट करता है? तो वो एक तो थायराइड हॉर्मोन्स को ट्रांसपोर्ट करता है। ये खुद में ही फिजियोलॉजी का क्वेश्चन था कि ट्रांसथायरेट्रिन क्या क्या कैरी करता है। तो ये थायराइड हॉर्मोन्स को ट्रांसपोर्ट करता है और ये ट्रांसपोर्ट करता है विटामिन ए को, दैट इज गोना बी रेटिनॉल, दैट इज रेटिनॉल, आर इज रेटिनॉल। हाँ, कई बार ये पेपर में ना एग्जाम में क्वेश्चंस बड़े फनी होते हैं, दैट यू स्टार्ट वंडरिंग कि इसके लिए मतलब इतना दिमाग क्यों लगाया ना, मतलब इतना कोचिंग वोचिंग क्यों किया, सिंपल पढ़ लिया होता। Then is transthyretin, that is thyroid hormone and retinol, and A would be standing for albumin, that is the negative acute phase reactant at the moment. So acute phase reactants are the ones which are focused along with two basic important disorders. Next we'll talk about complement system. कॉम्प्लीमेंट सिस्टम में टोटल मिला के 30 प्रोटीन्स प्रेजेंट होते हैं विद नेम्स लाइक C1 to C9, रेगुलेटर्स लाइक फैक्टर HI एंड प्रोपेल्डिन. दे विल आस्क यू बट द क्लासिकल एंड द अल्टरनेट पाथवे. तो अल्टरनेट पाथवे तो A से शुरू होता है, सो इट इज इम्यूनोग्लोबुलिन A दैट इज इन्वॉल्व्ड, एंड द कॉम्प्लीमेंट सिस्टम दैट वुड बी इन्वॉल्व्ड इन दिस वुड बी C2 to C4. In contrast, when it comes to classical pathway, two common antibodies would be involved, that is IgM and IgG, and the complement system activated would be C1. The third method in complement is lectin pathway, which would be activated by lectin component present in the cell wall of various bacteria, and C3 gets activated. So it is like C1, then C2 to C4 and C3 respectively. Try to remember the data at least for the alternate complement pathway, IgA C2 to C4. Then all of these steps would ultimately result in formation of membrane attack complex that they love to ask. क्योंकि अगर ये membrane attack complex नहीं होता है तो patient will be having recurrent meningococcal infections. So one of the commonest questions that comes in your exam for the topic of complement will say that recurrent meningococcal infections are associated due to, answer is C5 to C9 deficiency, which is the third point of this table. Recurrent meningococcal infections, recurrent meningitis in a teenager is primarily because meningococcus तो वैसे भी टीनेजर्स में कॉमन होता है एंड इट इज स्प्रेड बाय ड्रॉपलेट इन्फेक्शन, बट बार बार तो नहीं होता, वंस इन अ लाइफ टाइम इज बेसिकली मोर देन सफिशिएंट अबाउट इट, सो दैट इज C5 to C9 deficiency. Overall, the commonest complement deficiency is C2, and then C1 to C4 deficiency is involved in SLE. तो दो पॉइंट्स SLE के पॉइंट से याद करने हैं. एक तो SLE से रिलेटेड था नेटोसिस. वन ऑफ द क्वेश्चन सिंपली सेड which autoimmune disorder related to netosis, that is SLE, and second is C1 to C4 deficiency is associated with development of systemic lupus erythematosus, in which the type of hypersensitivity that is involved is type 3 hypersensitivity. So numbers करने हैं याद, C1 to C4 hypersensitivity होगी type 3, and I mean it's immune complex deposition that would present with the commonest system getting involved here is the commonest system getting involved is the musculoskeletal system. Then comes the role of hereditary angioedema. हेरिडिटरी एंजियोएडिमा इज अ कंडीशन जहां पे पेशेंट को लिप्स की स्वेलिंग होती है. इसको एस इनहिबिटर इंड्यूस एंजियोएडिमा से मिक्स मत करना. अगर किसी को एस इनहिबिटर से एंजियोएडिमा हो रहा है, उसमें तो स्टेरॉइड्स काम कर देंगे, उसमें तो एविल भी काम कर जाएगा. इफ अ पर्सन इज हैविंग लाइक एंजियोएडिमा इन्वॉल्विंग द लिप्स and the tongue primarily because of ACE inhibitor, I mean the steroids would be working. But if it is a hereditary angioedema, then there is no role of steroids, and the swelling jo hogi that would be seen with lips and the tongue, and then involve even the scrotum and the anterabdominal wall, but there would be no itching present. So what we will give in this patient would be a C1 inhibitor concentrate. The main treatment of this condition is C1 inhibitor concentrate, and the second one is a bradykinin antagonist. तो आप मुझे pharma से दवाई बता देना. Can you tell me from your knowledge of pharmacology what is the name of that bradykinin antagonist? What is that bradykinin antagonist which is used in management of hereditary angioedema? Okay, I'm having good answers, but bradykinin antagonist में जो पहला आंसर रहता है आपका, that would be given as icatibant. This drug was initially developed for management of hereditary angioedema only. Bradykinin antagonist is icatibant, and yeah, we do have monoclonal antibodies also against it, which can be used also. Like you, couple of them you were commented by you, but the specific question to answer to what I asked was bradykinin antagonist is icatibant in hereditary angioedema. Is icatibant and C1 inhibitor. Okay. Next is anaphylotoxins. One-liner question. Anaphylaxis, opsonization. I've already said C3b and immunoglobulin G. What are anaphylotoxins? So two components which are to be remembered would be C3, yeah, ecallantide. Yes, that's the second one direct is used. Ecallantide that will inhibit the formation of bradykinins. There are two mechanisms now. एक तो होगा कि bradykinin बनेगा नहीं. That is gonna be ecallantide, and second is bradykinin antagonist, that is icatibant. Then is gonna be anaphylotoxins. That is gonna be C3A and C5A. So couple of those questions that are related to complement system I have compiled in a single slide. First is obviously the normal pathway that I've described. Then are these questions. Do try to get a visual memory of these questions. Like in SLE it is C1 to C4, commonest is C2 deficiency, and then a couple of other allied aspects that I've explained, with the most important one being C5 to C9 deficiency seen with meningococcal infections. Obviously it will not be a one-liner. For meningococcal वो पहले कहानी सुनाएगा, fever, headache, nuchal rigidity, then will describe the Gram-Stein finding of meningococcus also, and then will say that it is able to ferment maltose and glucose, and will say that the organism को पहले भी 1-2 महीना पहले भी इसको meningitis हुआ था, 2 साल पहले भी meningitis हुआ था. So it's not about meningococcal meningitis. He wants to hear about membrane attack complex deficiency for this one. Okay जी. Next, we will revise some couple of macrophages. In the brain, there is obviously microglia. Like the brain में जो security system है वो microglia, और जो myelination के लिए cells होते हैं उनका नाम होता है oligodendrocytes. In the lungs, we'll be having alveolar macrophages, that is the dust cells, and they would be involved in like anthracosis. जैसे घर में अगर wooden cooking हो रही है तो wooden cooking के साथ में it is anthracosis that would be involved. And then is liver, Kupffer cells, kidney is the mesangium, placenta is the Hofpère cells. They are involved in Zika virus transmission vertically. और बच्चे में जो manifestation होती है, अगर जीका वायरस हो रहा है बच्चे में क्या होगा तो माइक्रोसेफली, और माँ में क्या होगा, मदर में क्या होगा तो गुलिन-बारे सिंड्रोम. टू न्यूरोलॉजिकल कॉम्प्लिकेशंस ऑफ जीका वायरस which are transmitted by Hofbauer cells should be remembered. What will happen in the fetus or what will happen in the baby is development of microcephaly, and what will be happening in the mother is possibility of GBS in a patient. Then are cells in the spleen for the security, that are littoral cells, osteoclast and synoviocytes. So these are, yeah, Clara cells in the bronchioles would also be present. They'll help in regeneration. So Clara cells are not that classical cells which are responsible for like security. Clara cells are basically for regeneration of the of whatever is the damage in the epithelium. The damage in the epithelium due to anthracosis. Okay. Moving ahead, next we'll talk about granuloma formation. So they always give you an image, and in this image you are able to see the Langerhans type of giant cells, where you can see the physical appearance there. Like that Langerhans tells that horseshoe appearance, either the word would be slipper, or instead of slipper he will say that it is like horseshoe appearance of cell that is present in granulomatous inflammation. With and without presence of caseating necrosis. This is a high power view where the giant cells have been shown, and this would be mediated by a gamma interferon. So interleukin 2 and gamma interferon play a role. Gamma interferon is the main cytokine which is involved in formation of granulomatous inflammation. This is not to be mixed up with that Langerhans cells. जो Langerhans cells होते हैं वो तो antigen presenting cells होते हैं, they are present in the skin, and Langerhans cells जो होते हैं वो तो star shaped होंगे. I mean Langerhans cells are gonna be star shaped, और उनके साइटोप्लाज्म के अंदर, लाइक इफ आई ड्रॉ रिप्रेजेंट करूँ तो उनके साइटोप्लाज्म के अंदर टेनिस रैकेट वाला अपीयरेंस वाले बिरबैक ग्रेन्यूल्स प्रेजेंट होते हैं. सो जस्ट ड्रॉ अ कंपैरिजन बिटवीन टू सेल्स. वन इज व्हाट इज कॉल्ड एज Langerhans, like the first one that I'm showing at the moment. This is what is called as Langerhans cells. Obviously, you know about it. And the second one is Langerhans. The Langerhans ones would be star shaped and it would be having that tennis racket. This would be causing the disease, na, Langerhans and histiocytosis, which will be having geographical skull. These are the antigen presenting dendritic cells. Antigen presenting dendritic cells, which are derived from the bone marrow. But the physical appearance of the cells would be totally different. Yeah, CD207, CD100 positivity would be given. CD1, in fact, CD1 and then CD207 positivity would be given for Langerhans cell histiocytosis. So I think granuloma pickup is pretty straightforward. The question was given like this. The question said कि एक बच्चा है, उसको लो ग्रेड फीवर रहता है ऑफ एंड ऑन, पैरासीटामोल देते तो ठीक हो जाता है, एंड देन द चाइल्ड वाज हैविंग अ सर्वाइकल lymphadenopathy. And then he said for this cervical lymphadenopathy, the doctor had done a excision lymph node biopsy. Maybe FNAC was also given, excision lymph node biopsy. And the image of the excision lymph node biopsy was showing presence of these Langerhans type of gels. So the clinical diagnosis that would be given on basis of the information that I provided is a tubercular cervical lymphadenitis. The diagnosis would be given as tubercular cervical lymphadenitis, which is one of the commonest forms of This is one of the commonest forms of extrapulmonary tuberculosis. Now we will compare this with presentation of sarcoidosis, in which there would be non-caseating granulomas and there would be no such giant cells that would be present. So let's now focus on that non-caseating granuloma kind of a question that would be for sarcoidosis. Before I do that, few more aspects for granulomas. Spot diagnosis, this was like given as an image stellate granuloma. So at the moment it is not a stellate shaped cell, but I'm talking about a stellate granuloma. In fact, I can write that on the top. Stellate granuloma, which would be seen with cat scratch disease. You can tell me the organism responsible for this. You can tell me the organism responsible for this for stellate granuloma. The organism would be Bartonella. The name of the organism in this case would be Bartonella henselae. And Bartonella henselae also causes a disease in HIV positive patients. So once more mentioning that, I mean non-caseating, though I had good answers there. Let me just attempt few more granulomas. Bartonella henselae in a HIV positive patient causes a disorder. The name of the disorder would be called as Bartonella henselae in HIV. That would be contributing to development of bacillary angiomatosis. So two diseases which are caused by Bartonella henselae are being discussed at the moment. One is bacillary angiomatosis and second is the stellate granuloma for cat scratch disease. Great, I had good answers there. Then we also read about lymphogranuloma venereum with that classical groove sign present where inguinal and femoral lymph nodes are separated by the taut inguinal ligament in the middle, where again stellate granuloma can be described. Then is the donut granuloma. That donut granuloma is a feature that you get with the Q fever. That would be Coxiella burnetii. This is a zoonotic infection, so most of the time would be contributing to like fever of unknown origin. And the last one is obviously the Durg granuloma that you love to hear about, falciparum malaria, for which that test is done, HRP2 card test, which helps you in easy identification. Durg granuloma, donut and stellate granuloma are standard easy questions which can be picked up in questions. And then comes the aspect of giant cells. So the types of giant cells that we come across would be one CD68 positive, that would be Langerhans type of giant cells. The word H is basically telling you, Langerhans here is telling you that it is a horseshoe shaped. The word Langerhans is telling you that it is H, it is horseshoe shaped. And if I contrast this with Langerhans, then if you look at the vocabulary Langerhans, the word R comes in, that is tennis racket appearance. I said it is antigen presenting dendritic cells in the dermis, but in Langerhans cells, it is like the tennis racket appearance. It is the R. I mean, if you have a better way of remembering it, I'm okay with it. Even without even without all these alphabet cues, you easily know TB versus Langerhans. But yep, I wanted to just highlight that in Langerhans cell histiocytosis, the dendritic cells will turn against self and they will be causing damage in the skull. So they'll put up a question on an adult patient, and then in this adult patient, he will say, or in a child most of the time, he will say that there is this presence in a child of geographical skull. Normally we read about like raindrop configuration of lytic lesions in multiple myeloma. वैसे ही यहाँ पे bigger lesions would be present that would look like map of a country. So geographical skull, the word is geographical skull, is seen in Langerhans cell histiocytosis. And That's because of the antigen presenting cells in the epidermis that can even erode the bone of the patient. Once we are sorted with these, then we'll focus on Totten cells. Totten cells would be seen with respect to tendon xanthoma. And well, what is the cause of development tendon xanthoma? Then most of the time it would be a familial hypercholesterolemia. Like this is an autosomal dominant condition that I'm talking about, familial hypercholesterolemia, that is by Fredrickson classification type 2A hyperlipoproteinemia. The presentation is tendon xanthoma. The presentation is tendon xanthoma that can be seen with familial hypercholesterolemia. In this, the appearance of the cell will be all through. इसमें तो पूरा का पूरा ही जैसे अगर आप देखोगे तो 360 degrees पे that round nucleus can be seen. Unlike that horseshoe appearance, this time it was like all 360 degrees. So we are gonna call it a tendon xanthoma for familial hypercholesterolemia. And then if I move on to the extreme right hand side, that is Warthin-Fingilti. Warthin-Fingilti would be a feature that would be seen with measles, in which we will be having a exanthum as well as an enanthum. Enanthum मतलब lesion inside the mouth होगा, that is Koplik spots, and exanthema would be that rash जो कि कान के पीछे से शुरू होती है and then will be involving whole of the body subsequently. It would be a maculopapular rash. So three types of giant cells were discussed: Langen, Totten, and Warthin-Fingilti. Now we will focus on two more aspects. One is for that owl eye appearance. दोनों में ही owl eye है in fact. But in one of them, the owl eye appearance is with respect to the lymph node biopsy of the patient. And in second one, it is with respect to urine microscopic examination. I'm doing a urine microscopic examination in a patient who underwent a kidney transplantation. I can see that blue thing inside the nucleus with a perinuclear halo. Like you can see a clear area that is present here. So it's an owl eye and there's a perinuclear halo also present. Obviously, the answer in this case will change over to that of CMV, cytomegalovirus, which is an important cause of graft failure. So the first one that I described was the owl eye appearance on the lymph node biopsy for Reed-Sternberg cell for Hodgkin's lymphoma. Obviously, that would be CD1530 positive. But if I say urine microscopic examination is showing owl eye appearance, then it would be a case of graft failure. Like the guy had undergone a kidney transplantation maybe 6 months ago, and at the moment, due to like the aspect of immunosuppression, because anytime kidney transplantation is done, the patient's immunity will be reduced. So immunity कम होती है तो patient को owl eye appearance of cytomegalovirus can be present, and all of these are like very standard easy questions that can be asked to you. Next, I'll introduce the concept of wound healing. For wound healing, they have always asked about vitamin C and zinc and what is the function. So vitamin C का जो main function रहता है, that would be hydroxylation of two things. It would be hydroxylation of lysine as well as a proline. And then the question has become little more technical by saying कि जो hydroxylation हो गई उसमें hydroxyproline बनता है, hydroxylysine बनता है. So hydroxylysine क्या करता है और hydroxyproline क्या करता है? तो आपको पहले तो hydroxylysine याद करना है. Lysine में L से याद करना है कि वो क्रॉस लिंकिंग करवाएगा. Hydroxylysine with the L will be responsible for development of cross linking, and by that you can remember hydroxyproline is responsible for stabilization of the triple helix. I repeat the data once again. Vitamin C क्या करता है scurvy में? I mean vitamin C why it's important for like growth is, and why in scurvy bleeding would be occurring is because the triple helix of collagen will not be stabilized. Hydroxychloroquine होगा ही नहीं, तो hydroxychloroquine stabilizes the triple helix of triple helix of collagen, and then for cross linking it is hydroxylysine that is required. So single best answer is what is function of vitamin C? Hydroxylation of lysine and proline, and what does lysine do and what does hydroxyproline do? That I have tried to explain by alphabet L, the cross linking part. जिंक क्यों चाहिए होता है हीलिंग प्रोसेस के लिए? एनी टाइम आफ्टर सर्जरी वी गिव सप्लीमेंट्स, दो सप्लीमेंट्स आर हैविंग जिंक प्रेजेंट. जिंक इज रिक्वायर्ड फॉर फॉर्मेशन ऑफ बेटर एक्टिविटी ऑफ डीएनए एंड आरएनए पॉलीमरेज, बिकॉज फॉर वुंड रिपेयर यू नीड मोर सेल फॉर्मेशन, फॉर मोर सेल यू नीड मोर आरएनए, यू नीड मोर डीएनए. सो जिंक इज इंपॉर्टेंट फॉर डीएनए एंड आरएनए पॉलीमरेज. एंड द थर्ड कंपोनेंट इज कॉपर. अब कॉपर वाले एस्पेक्ट पे आते हैं. I said two aspects at the moment. I'll say them once again fast, 15 seconds. Collagen is for hydroxylation of lysine and proline and the respective functions as I explained. Why do you need zinc? Because you need cellular repair. Cellular repair would mean DNA, RNA, because cells are being formed. So for DNA and RNA polymerase activity, zinc is required. And the third aspect is that of copper. If he says about copper, तो उसने बोला कौन से एंजाइम की एक्टिविटी के लिए. जैसे Menkes डिजीज में किंकी हेयर होते हैं, fragile hair होते हैं. Why that kinky hair is present is because of the enzyme activity which is affected, that is lysyl oxidase. Lysyl oxidase क्या करता है, ये भी क्रॉस लिंकिंग करता है आउटसाइड द सेल. वन इज इनसाइड द सेल, सेकंड इज आउटसाइड द सेल. So remember, cross linking outside the cell is by a copper dependent enzyme by the name of lysyl oxidase, and in case the activity of this lysyl oxidase is lesser, the cross linking of collagen is poor, and that is why brittle hair or like kinky hair in Menkes disease can be present. So I've said at a like at that enzymatic level, I've tried to explain aspect related to vitamin C, I've explained aspect related to zinc, and I've explained the aspect related to copper. I'll say them fast once again for permanent memory. I'll move the slide. Try to focus. For vitamin C, it was cross-linking and hydroxylation. Two amino acids required, proline and lysine. Hydroxylation will form hydroxyproline and hydroxylysine. 10 seconds gone, remaining 5 seconds. Zinc, DNA and RNA polymerase activity, and copper for lysyl oxidase activity. I hope yaad ho gaya hoga, so that if they come, overlapping of these does not happen. And then comes the aspect of like what is the common cause of delayed wound healing. Obviously it is infection. This is taught in surgery also. Surgical site infection हो जाए तो wound healing भी होता है, और कई बार तो burst abdomen भी हो सकता है. Then what is the initial collagen that is formed? So initial collagen that will be formed is type 3 collagen, and later on the collagen that is formed is more stronger, that is type 1. पहले बनता है type 3, फिर बनता है type 1 collagen. Type 1 collagen is like relatively much more stronger, and at this moment I also want to say cornea में भी type 1 collagen होता है, because it is responsible. Cornea is like is literally like a protuberance of the eye for our whole life. So collagen 1 gives structural strength to the cornea, and collagen 5, type 5 collagen is responsible for the transparency of the cornea. दो बातें मैंने बोली, एक तो type 1 collagen is responsible for giving strength to the cornea, and second I said type 5 collagen is responsible for the transparency that is present in the cornea. At this moment I mentioned regarding aspects related to wound healing, and then a couple of images which can be asked up. एक तो उसको नाखून के साइड पे लग गई थी, and then this proliferation of tissue which is called as proud flesh or excessive granulation tissue, not to be mixed up with obviously a keloid versus hypertrophic scar. keloid जो होता है that will always cross the wound margins. जैसे ये लीडिंग ear piercing के लिए गई थी, अब ear piercing के लिए तो होल बड़ा छोटा सा करते हैं through which that earring can be put, लेकिन you can notice the lesion on the earlobe of the patient and it can cross the initial site of injury. और this patient को scaphoid fracture हो गया था, तो इसकी सर्जरी की रिक्वायरमेंट हुई थी. Maybe scaphoid fracture, radius fracture had occurred, and the patient required surgery. So at the site of incision now, like there's a huge keloid that is present, which is like haphazard collagen bundles on histology would be present, whereas hypertrophic scar will be limited to the area of the scar only. Like this guy this patient underwent a CABG, so it was like a incision on the chest, or patient went a midline laparotomy. So if the lesion is located only to the site of the scar, then we call it a hypertrophic scar. But then if it is going to be a perpendicular to Langer's lines all the time, yes, because that is one of the reasons why the scar is developing. If the incision is along the Langer's line, then the chances of scar formation will be significantly reduced. Then cosmetically appealing scars will be formed. जैसे appendicectomy जो scar होता है उसका नाम Lange incision होता है, तो that Lange incision वाला जो scar होता है वो cosmetically appearing होता है, वो Langer's lines के साथ साथ चलता है. But this incision was given perpendicular to the Lange lines, and that is why the hypertrophic scar would be occurring in a patient. So in this particular pages, what we have studied is aspects related to like inflammation, and then related to wound repair, and obviously the type of giant cells. Non-casetic granulomas कहाँ पे मिलते हैं? Somebody had commented on that, but I'll just make a list here. I mean, anytime you read about non-casetic granulomas, the disease number 1 that is always to be thought of is sarcoidosis. Somebody had commented already, but again you can mention this here. Yes, guys, sarcoidosis, non-casetic granulomas, granulomatous colitis, no, Crohn's disease. I mean, 2 times when they always love to ask about non-casetic granulomas is, one is the aspect of sarcoidosis, and second is he'll talk about inflammatory bowel disease. Whenever you read the word granulomatous colitis, it is Crohn's, and if I say the word non-granulomatous colitis, then it would always be ulcerative colitis. Yeah, even like leprosy could be one such example where we could be having this non-casetic granuloma present. As far as Hodgkin's lymphoma is concerned, it would not be a very appropriate way to say non-casetic granuloma, because there it would be more classical histopathological findings that would be present. For sarcoidosis, the question will always, the question of sarcoidosis that is asked in the exam will begin with a young female, and then he will say that she is having shortness of breath. And when the doctor has done chest x-ray, it will show a bilateral hilar lymphadenopathy. It will always be Bilateral hilar lymphadenopathy, that is pressing on the airways, which is causing breathing difficulty. And then he will say ACE levels are elevated. That's one of the core things that you have to pick up. Young female, shortness of breath, bilateral hilar lymphadenopathy, and then ACE levels elevated is for presence of sarcoidosis. You guys can help me out with the investigation of choice for sarcoidosis. Best test for diagnosis sarcoidosis. Yes, guys. Yeah, we can have Garland sign when those are X-ray findings that are present. Yes, what is the investigation choice for diagnosis of sarcoidosis? Quick answers, please. Sir, it will always be a biopsy. It will, most of the time it will be a CT guided, because this is hilar lymphadenopathy. So it would be a CT guided lymph node biopsy. That would help me. If this is not in the options, then I will go for bronchoalveolar lavage. सर बायोप्सी ना नॉन केस, तभी तो ऐसी तो क्वेश्चन था. यंग फीमेल, शॉर्टनेस ऑफ ब्रेथ, bilateral hilar lymphadenopathy, CT guided biopsy shows non-gazetting granulomas, and then he said what is the diagnosis. Slide देखने का जरूरत ही नहीं. I mean, if you are gonna go through this, then the answer will become immediate that the answer is sarcoidosis only. Second, he will say bronchoalveolar lavage, और उसमें CD4 CD8 रेशो दिया होता है. आपके करियर में CD4 CD8 रेशो 2 बार देते हैं. एक HIV के केस में जिसमें चेंज हो जाता है 2:1 से लेस हो जाता है, और सेकंड होता है ब्रोंकोअल्वेलर लवाज में CD4 CD8 रेशो मोर देन 3.5. प्लीज अप्रिशिएट द फैक्ट कि ये जो CD4 CD8 काउंट है, दिस इज नॉट प्रेजेंट इन द ब्लड. This is CD4 CD8 count not in the blood, it is in the ball, that is in the bronchoalveolar lavage of the patient. So you need to remember that aspect है. और एक और चीज बोलना चाहता हूँ, sarcoidosis will also be causing involvement of the lung. It will cause reticular shadows in the lung, and because of these reticular shadows in the lung, we can even do a lung biopsy in the patient in the later stages. पहले तो hilar lymphadenopathy होती है, but then it causes pulmonary fibrosis, so we can also do a lung biopsy in this patient. That means we can also be doing is a CT chest. And the CT chest in this case will be revealing presence of reticular shadows, peripheral reticular shadows, and hilar lymphadenopathy, both would be present. But like in the order where all of these are given, like he might mention CT chest showing reticular shadows, he may say bronchoalveolar lavage showing BAL value more than 3. CD4 CD8 more than 3.5, and then he might say the word CT guided lymph node biopsy, lung biopsy, all of them described, then answer is CT guided biopsy. आई स्किन के इन्वॉल्वमेंट्स पूछता है, दैट इज इन द फॉर्म ऑफ यूवीआइटिस. Then the salivary gland involvement can cause development of parotitis and bilateral seminal palsy. तो अब थोड़ा सा मेडिसिन में चला जाएगा, because bilateral seminal palsy is read with you by GBS, and also bilateral seminal palsy is seen with patients of sarcoidosis. Somebody had mentioned gallium scan. वो gallium scan ना सिर्फ ocular parotid gland का involvement को हाईलाइट करने के लिए यूज करा जाता है. तो gallium 67 scan is not a very good way for identification. In the MCQ, even gallium 67 scan was given. But the single best answer is जो मैंने बोला, that is a CT guided biopsy for this patient, and we can give steroids. और एक मेडिसिन वाला एस्पेक्ट एक और बोल देता हूँ, this condition can contribute to synthesis of vitamin D3. तो vitamin D3 अगर sarcoidosis में बनेगा तो person will be having hypercalcemia. So the question of your exam said which of the following condition will be having steroid responsive hypercalcemia. That steroid responsive hypercalcemia is a feature that is seen with steroid responsive hypercalcemia is seen with sarcoidosis. So we are sorted as far as non-gazetting granulomas are concerned. Next we'll talk about couple of diseases of immunity, which is the last thing that we need to handle in GPath component. Yes guys, question for you guys, what are the CD markers for natural killer cells? And I think when I saw you in a face-to-face class, I did speak about it, so I expect more people to comment about this one. Yes guys, CD markers, no, for natural killer cells. Then you have to remember they're inhibited by, they're activated by, what is the function. All of these are questions which are to be remembered, including one of the main function being antibody dependent cell cytotoxicity. While I'm writing the full form here, antibody dependent cell cytotoxicity. Yes, very good. Antibody dependent cell cytotoxicity is the function of natural killer cell, which they love to ask. The markers would be, yes, it is 16, 56. वो मोदी जी बोलते हैं ना 56 इंच का सीना, मोदी जी बोलते हैं हमेशा 56 इंच का सीना. So it is 16, 56 and 94, and the CD natural killer cell is like inhibited by cells that express MHC1. तो ये खुद को अटैक नहीं करता. I mean, it will not attack self, but sometimes cancer cells or tumor cells will also result in MHC1 down regulation. I mean, the point is it is inhibited. The natural killer cell is inhibited by cells that inhibit, that express MHC1, but then it gets activated by cancer cells where MHC1 is downregulated. MHC1 is like a सुरक्षा कवच. वो basically इस सेल को खुद को अटैक करने को prevent कर रही होती है. And one of the main functions of this would be release of perforin. It is also help to kill viruses. जैसे viral infection है उसमें भी natural killer cells play a role. So they will release a perforin which will punch a hole in the cell wall of like punch a hole in the membrane, and thereby like the antibody mediated cell cytotoxicity can be mediated. So NK cell में तो mainly it is like the numbers which are to be remembered and the inhibition by MHC1. Now we'll talk about T cells and B cells. Can you tell me the function of B cells by the way? Like T cell का तो समझ में आ गया, killer action होता है. B cell का main function क्या होता है? I would like everybody to comment in the chat box what is the main function of the B cell. Option दे देता हूँ. एक हो गया antigen detection, एक हो गया antibody production. Single best answer बोला antigen detection, antibody production. Antibody production में भी जैसे लिखा antibody production like specialized antibody कर देता हूँ like IgA or production of immunoglobulin E. So options are antigen detection, production of immunoglobulin A, production of immunoglobulin E. Can I have single best answer for this? What is the main function of B cell? I'm having people, I think yes, it is the main function is antigen detection. जो मेन फंक्शन होता है बी सेल का वो एंटीजन डिटेक्शन है, साथ में एंटीबॉडीज भी बनाता है, पर कौन से वाले बी एंड डी, और उसके बाद में आइसोटाइप स्विचिंग होती है. सर आप सबने ये पढ़ा हुआ है, बी सेल का जो मेन फंक्शन है वो एंटीजन डिटेक्शन है. मैं स्लाइड चेंज करके दिखा रहा हूँ. बी सेल क्या करेगा, उसका प्राइमरी फंक्शन तो एंटीजन डिटेक्शन होता है along with the expression of IgM and IgG, and then it takes the help of T cell and goes into isotype switching. Isotype switching का मतलब है फिर वो स्पेशलाइज एक्टिविटी करता है और बाकी एंटीबॉडीज बनानी शुरू कर देता है. जैसे कि एम और डी तो पहले बना रहा था, फिर GAE वाली एंटीबॉडीज बननी शुरू हो जाती है. सो माय पॉइंट इज कि पहले एम और डी बना रहा था ना, MD वाली एंटीबॉडीज बना रहा था, एंड देन इट कैन प्रोड्यूस द स्पेशलाइज्ड एंटीबॉडीज लाइक GAE ऑल्सो. सो द क्वेश्चन इज आस्क्ड एज सिंपली व्हाट इज द फंक्शन ऑफ द बी सेल. तो एंटीबॉडी प्रोडक्शन ना करें, फर्स्ट आंसर होगा एंटीजन डिटेक्शन. Now the aspects to be remembered would be, पहले तो हमने नेचुरल किलर सेल्स के बारे में पढ़ा, उसके नंबर्स को याद किया, 16, 56 एंड 94 with the inhibition part and ADCC. 3 points to be remembered for like natural killer cell. Then is the T cell related details. For T cells, the CD markers are pretty simple. CD1 से CD8 and CD28. pan T cell marker is CD3. जैसे हम pan B cell marker पढ़ेंगे, वैसे pan T cell marker is CD3. And then is helper in killer cells that I don't need to tell you. Normal CD4 CD8 ratio is 2:1, and this value will be affected in, like if it says increased in bronchoalveolar lavage, then your answer would be the value is more than 2:1. It becomes 3.5:1 in a patient of sarcoidosis. Yes, antigen detection can express IgM and IgD. Exactly. Yes, MD, right? That's the word. Increased in, then the answer would be given as bronchoalveolar lavage in sarcoidosis, and this would be reduced in HIV infection. That would be called as Slim's disease. CD4 CD8 ratio normal is 2:1. उल्टा हो जाती है HIV पॉजिटिव इन्फेक्शन में, HIV में या एड्स में, स्लिम्स डिजीज जिसको बोलते हैं, एंड इज इंक्रीज्ड इन बाल इन सार्कोइडोसिस. ये फिर से बोल रहा हूँ, ये बॉडी फ्लूइड में बढ़ रहा है एंड इट इज नॉट इन द ब्लड, बट व्हेन इट कम्स टू स्लिम्स डिजीज और HIV, इट इज इन द ब्लड दैट वी आर कंसिडरिंग. सो फर्स्ट एस्पेक्ट दैट आई हैव टॉक्ड अबाउट इज व्हाट इज द फंक्शन, व्हाट इज द नेचुरल function natural killer cells, what are the CD markers for T cells, and now what we will study is the function related to the B cells. ओके, CD4 पे और आ जाते हैं. CD4 के 2 पॉइंट्स हो रहे हैं. ओके, CD4 cells would be 2 varieties, TH1 and TH2. The TH1 will be producing interleukin 2 and gamma interferon, and that is responsible for formation of granuloma. Earlier I had said granuloma के लिए production of gamma interferon. पहले मैंने एक ही पॉइंट बोला था that for production of gamma interferon it is gonna be for granuloma I had mentioned gamma interferon G and G. Now cytokine also, that is interleukin 2 1 2, that is TH1 will be producing interleukin 2. 1 and 2 numbers are going to be close together along with gamma interferon that plays a role with granuloma formation and will be targeting intracellular pathogens. Then comes TH2. This would be mainly involved in asthma. जो TH2 cells होते हैं, they are mainly predominant in type 2 asthma. मैं ये नहीं कह रहा कि एस्थमा की हाइपर सेंसिटिविटी रिएक्शन चेंज हो गई. एस्थमा इज टाइप 1 हाइपर सेंसिटिविटी ओनली, बट एक एस्थमा होता है जो टाइप 2 एस्थमा होता है विच इज मोर रिस्पॉन्सिव टू स्टेरॉइड्स. आई रिपीट माई स्टेटमेंट, type of hypersensitivity in asthma will remain allergy only. So there is no problems with that. But there's a special type of asthma that is called as type 2 asthma. Type 2 asthma जो होता है उसमें इंटरलूकिन 4, 5 एंड 13 बनता है और उसके लिए हमारे को स्टेरॉइड्स देने पड़ते हैं. लेकिन प्रॉब्लम है कि अगर हम ओरल स्टेरॉइड्स देंगे तो उससे पेशेंट को कुशिंग सिंड्रोम के मैनिफेस्टेशंस आ सकते हैं. सो व्हाट वी कैन डू हियर इज व्हाट वी कैन डू एट द मोमेंट इज इफ इट इज गोना बी स्टेरॉइड्स एंड दे आर गोना कॉज साइड इफेक्ट्स, आई कैन बी यूजिंग बायोलॉजिकल्स इन टाइप 2 asthma. One of the special biologicals for type 2 asthma that I want you guys to remember would be against interleukin 5 receptor. You see, interleukin 5 is going to be responsible for eosinophil activation. So there's a special molecule that is available which will basically block the interleukin 5 receptor, and thereby the histamine release will also not occur, and the allergic reaction that is associated with asthma will also be taken care of. Why you are studying all this is from the pathology part is because pharma is an extension of pharmacology only. कि अगर आपको ये पता है कि interleukin 4 plays a role with respect to isotype switching. When I say the word isotype switching, that means that B cell can now be producing remaining antibodies. Remember earlier it was producing only MD. M and D. Now it is G, A and E. Earlier it was MD and G, A and E. So specialized function of the B cells. What do you mean by the word isotype switching is that interleukin 4 will ensure that your B cell now does specialized function. That specialized function is that remaining antibodies G, A, E, it can be produced. Interleukin 5 is playing a role in eosinophil activation. So I said अगर आप interleukin 5 receptor block कर देते हो, so the eosinophil activation will not occur, the histamine release will not occur, and thereby the asthma attacks can be controlled, and therefore a biological which is now available as like once a month injection for asthma. That once a month injection for asthma is what is by the name of benralizumab. So keep the focus on, guys. What I am teaching you at the moment is interleukin 4 isotype switching. That means specialized function of Bombay cells, the B cells. Interleukin 5 is for interleukin eosinophil activation. If you block interleukin 5 activation by benralizumab, the asthma severity in the patient can be reduced. And interleukin 13, that again plays a role with mucus production. So we have drugs like dupilumab. So do read up the biologicals for asthma because they love to ask about it in the exam. And therefore interleukin 4, interleukin 5 and interleukin 13, they will be having a role. Yes, very good. Dupilumab will be having action on interleukin 4 as well as interleukin 13. So TH2 produces IH4, IL4, IL5 and IL13. And why are you studying this is because these chemicals are involved. These cytokines are involved in pathogenesis of allergy and asthma, and then again response to parasites, because anytime you are having parasitic infestation in the body, the eosinophil count in the body will be increased. The best example of that is a condition found in India, tropical pulmonary eosinophilia. We are a tropical country, especially patient will be from Odisha, West Bengal, and he'll be having X-ray showing bilateral fleeting opacities and eosinophil count would be elevated. That was microfilaria responsible for tropical pulmonary eosinophilia as a disease. So let's do a quick recap at the moment. I'll move the slide. TH17 plays a role in neutrophil recruitment. I'll come to that also, but let us just try and remember this information that I mentioned. First is TH1 cell. That TH1 cell, then is TH2 cell, right? So the TH1 cell is related to interleukin 2 and the production of gamma interferon, which causes granuloma production. That is line number 1. I want you to remember. I'll say that again. TH1, bringing it to focus. TH1 cells produce interleukin 2 and gamma interferon responsible for granuloma production. That is one question that you need to remember. Aspect number 2 to be remembered is TH2 cells would be responsible. That is a variety of CD4 cells for interleukin 4, interleukin 5 and interleukin 13 that play a major role in pathogenesis of asthma. That is why now we are having once a month injections for asthma, and we don't need to take that daily nebulization part. No, taking a puffer for asthma, taking that nebulization for asthma is very, very cumbersome. So you will have patients who will be asking for biologicals. And when I talk about those biologicals, one of the example of that is benralizumab. That's the importance of studying TH2 cells. And also remember, type 2 asthma is a variant of asthma which is like more responsive to steroids. Then is TH17, that would be producing interleukin 17 that plays a role in neutrophilic recruitment, and this is the one which is defective in Job syndrome. I mean, this step is defective due to a mutation, due to this STAT3 mutation that you guys read. Due to the defect of the STAT3 mutation that you read, there's a defect that comes up, that is what is called as Job syndrome, where recurrent infections would be coming because of a defective neutrophil recruitment. So 3 aspects is what I've highlighted at the moment for CD4 cells, and now I'll focus on CD8 cells, which will be one responsible for inducing apoptosis via CD95, which is a part of the extrinsic pathway, and caspase involved is caspase number 8. I explained to you extrinsic even number 8 and 10 involved. Second, it is responsible for production of perforins. These perforins will punch a hole in the cell wall of the bacteria, and therefore the killer cell will be able to do its job. Killer cell will be able to do its job. Once you got a baseline information regarding the information that I've said, now comes more details for B cells. One, he simply said for B cells, that's Epstein-Barr virus. Like you are aware, Epstein-Barr virus is responsible for causing multiple cancers. In fact, I can write those cancers at the moment. Epstein-Barr virus क्या क्या करता है? So Epstein-Barr virus is responsible for causing nasopharyngeal cancer. Epstein-Barr virus causes development of Burkitt's lymphoma, Hodgkin's lymphoma, non-Hodgkin's lymphoma. If you just look at the data that I'm describing at the moment, like the question is like not what are the cancers which are caused by Epstein-Barr virus, we all know that. He will say it will enter the B cell and will hijack the nucleus. I mean, Epstein-Barr virus is literally gonna hijack the command center. It is gonna hijack the command center of the it's going to hijack the command center of the cells. It's going to hijack the command center of the nucleus. I mean, the nucleus is the command center of the cells, and promote abnormal proliferation of cells. Very good. CD21 is the number that I was looking for. Then it will be responsible for production of naive B cell, will be responsible for production of two antibodies. One of the antibodies is given IgM. The second one that would be produced here, I mean, the main antibody that is produced is IgM and IgD. MD, and then this naive B cell will be getting converted into a mature B cell, which will be producing the remaining antibodies. The CD markers are multiple, that 19, 20, 21 तो आपको पता ही है, but if he says what is a pan B cell marker, it is CD19, just like हमने पढ़ा था pan T cell marker is CD3. Similarly here, हाँ जी, राम to you. Okay, this is just to prove that this is a live session. Okay, क्योंकि मैं थोड़ा सा data बोलता जा रहा हूँ, तो people tend to think it's a recorded session. No guys, it's not recorded. So pan T cell marker जो है, that is CD3, and pan B cell marker is CD19 at the moment. And as I explained, B cells can do isotype switching, मतलब वो specialized function करते हैं using CD40 receptors. That all of that is like very standard data that is asked. Naive B cells will be producing what? Antigen detection, IgM and D, and then the specialized function is G and A antibodies via CD4. ओके जी, हाँ नहीं कोई बात नहीं, वो कई बार ऐसा होता है कि CD4 ही पड़ा होता है, बट देन दे लव टू आस्क अबाउट द टेक्निकल पॉइंट्स ऑफ varieties of CD4 cells, and they like to ask regarding the special features of B cells that I've explained. Okay जी. Next, we'll study regarding the various types of hypersensitivity reactions. Very easy to identify. Acid is the mnemonic for it. Obviously, type 1 will be anaphylaxis. आप antidote बोल देना anaphylaxis का, और cause of death बोल देना anaphylaxis का. C would be cytotoxicity. I'll give you an example of this and ask you what will you do. Then is type 3 hypersensitivity, that is immune complex formation. And then is obviously the delayed hypersensitivity. So I'll put up questions based on these aspects to you guys. The first question for you guys is which of the following? What is the cause of death in anaphylaxis? What is the investigational choice for diagnosis of anaphylaxis? What is the antidote that would be used in the patient? Yes. So the cause of death in anaphylactic shock would be answered as laryngeal edema. Very good. What is the investigational choice and what is the treatment? The treatment would be adrenaline or epinephrine that would be given to the patient. Please comment in the chat box. Would you like to give it undiluted, or would you like to dilute it to 1:10,000? Would you like to dilute it or give it undiluted? Yeah, 0.5 milligram would be given. It would be 1:1000 concentration. What is the investigation that would help you determine? Yeah, it is not respiratory failure, it is laryngeal edema for anaphylaxis. Yes guys, EP will be given. What is the best test to confirm? I mean, you have saved the patient. Now what is the cause of what will be the IUC for this condition? Yes. Fourth question is, which cell mediates anaphylaxis, eosinophil or basophil? Cell related to development of anaphylaxis, eosinophil or basophil? Cytokine involved is primarily interleukin 4 only. What is the main cell which is involved? Yes, it is undiluted adrenaline. The undiluted adrenaline will be at 1:1000. Yeah, I just increased the number of questions here, so expect quick answers from you guys with respect to this. Which is the cell which is involved for pathogenesis of anaphylaxis? No, it is not eosinophil. This is a common misconception that most people have. The common cell which is involved is basophil. It is basophil mediated interleukin 4. It is the BAP of allergy that I'm talking about. Guys, it is not eosinophil. It is basophil mediated eosinophil 4. It is not eosinophils. दोबारा से देखना. Anaphylactic shock is not eosinophil mediated. It is, like I said, it is the BAP of allergy. It is like the super allergy that I'm talking about. So it basophil mediated. The question is regarding it is a basophil mediated interleukin 4 release. The cause of death is laryngeal edema. The test for diagnosis never came up on the discussion anyway. So I hope that you guys are familiar with it. The test would be called as serum tryptase levels. There are 1, 2, 3, 4, 5 questions that I've covered. I'll just say the questions once again. Basophil mediated interleukin 4 release, and this will cause laryngeal edema. The main test for confirming the diagnosis is serum tryptase levels, and the investigation that will and the treatment we give is undiluted adrenaline 1:1000 concentration. Next, for cytotoxicity, the antibody involved is IgM. The question is that a patient's blood group is B and blood group A was given to the patient. So that would be a situation of a mismatched blood transfusion. Like, what is happening here is that the blood group of the patient is B, and by mistake it was due to a clerical error, like the barcode was not matching, but still the blood was given. Mismatched blood transfusion was given to a patient. That would be IgM, and there would be cytotoxicity. So the cells that are given to the patient will begin to die. So that is mismatched blood transfusion. The question said, what is the type of hypersensitivity reaction that is seen here? So the antibody that is involved in this case is IgM, unlike immunoglobulin E, which is related to anaphylaxis. And this would be type 2 hypersensitivity reaction for mismatched blood transfusion. The next question I've solved myself only. Mismatched blood transfusion is example of type 2 hypersensitivity, and most of the time these patients can develop acute kidney injury. I mean, the question will begin by saying flank pain, and then the person can have AKI or acute tubular necrosis because hemoglobin will block the tubules of the kidney. So that would be possible reason, one of the reasons why patient can die. Then for the immune complex mediated, it would be SLE as the best example. And for delayed hypersensitivity, I'll give you a couple of examples subsequently, but these common hypersensitivity reactions in the form of hypersensitivity reaction 1, 2, 3, and 4 is usually asked. Let us now focus on delayed hypersensitivity reaction for the following disorders. The mnemonic is MCH. That would be the following conditions which are given. First is multiple sclerosis. Then is Mantoux test and Lapermain test that are useful for diagnosis. Multiple sclerosis in some books is also given as type 2 hypersensitivity. So they can be overlapping information. It can be 2 as well as 4 present. But yeah, in the long run, it's an autoimmune process, so can be contributing to this. Then is contact dermatitis. That is like nickel artificial जो jewelry होती है, nickel की artificial jewelry that can contribute to contact dermatitis in a patient, and Crohn's disease. Then is MCH में H, that would be then it's gonna be HP, that is hypersensitivity pneumonitis. The condition that I'm talking about is, this is a farmer. He walks into a barn जहाँ पे hay is kept, hay is where the dried grass is kept, that is chara of the animals is kept, and he is inhaling a fungus. So can you tell me the fungus which is responsible here? Oh my god, Mayur. You are a consultant pathologist. Oh, great. Good to interact with you, man. Okay. Yeah. Patch test again. Yes. So I can mention that also, patch test. That would be for diagnosis of Peyer's disease. Yeah, very good. The hypersensitivity pneumonitis is farmer's lung. Earlier, farmer's lung was classified as type 3 hypersensitivity, but in the current edition of Harrison, it is given as type 4, so we'll go by that. And well, in farmer's lung, the person will be exposed to a fungus that would be by the name of thermophilic actinomycetes. Yes, it is Micropolyspora fani. That is one, as you mentioned rightly. It is not aspergillus. It is not aspergillus. It is thermophilic actinomycetes. And then is Micropolyspora fani. So do take care of it. It is not aspergillus. That is one of the common mistakes that will be we'll be mentioned. Yeah, pathology phenomenon. Exactly. that is pathology phenomenon. Patch test would be for contact dermatitis. Patch test is for contact dermatitis, and it is pathology phenomenon for Behçet's disease, which would be most of the time also written in question as Silk Route disease with an association that is HLA-B5 or HLA-B51 positivity. Yes. So patch test जो मैंने लिखा था that is for contact dermatitis. Patch test is for contact dermatitis and it is pathology test or pathology phenomenon where you use a sterile needle and you make a prick on the forearm of the patient. That was for Behçet's disease. And yeah, I think it's now clear it is thermophilic actinomycetes and it is not aspergillus as we usually think for type 4 hypersensitivity reaction. Yeah, scrotal ulcer can be present. Dhanush, you have a good point there. Serum sickness would be classified as type 3 hypersensitivity, sir. Serum sickness is like anti-snake venom की वजह से दिया था. Then our type 1 is easy. ABCD is a mnemonic, allergy, atopy, then bronchial asthma, Cassoni's reaction. Cassoni's would be with dog type form, that is Echinococcus granulosus. The same one in which we read about that water lily sign and that cartwheel pattern on ultrasound is dog type form. Nowadays, we don't use Cassoni's reaction. It is obviously serological testing and sonographical evidence that is used to demonstrate the presentation of this. And then is drugs, penicillin, cephalosporins, and anti-snake venom, which can contribute to this. No, it is not blood transfusion that you were talking about. It is about platelet transfusion. You put up a question, right? That transfusion wala pucha na apne, that is transfusion is for platelets that you were saying 10K and 20K. So it is 10K as an answer from Harrison for platelet transfusion. I think the language of your question, Dr. Sahib, was a little mismatched there. Okay. Yeah. Then two classical names are to be remembered: Prasunic-Kushner reaction and Theobald-Smith reaction. Prasunic-Kushner reaction simply means that if you are having allergy and if your serum is given to me, then even I will develop that allergy. I'll also have wheals on my body. I'll keep on scratching. And the Theobald-Smith antigen means that they can be anaphylactic shock developing on reintroduction of the allergen. So those are just a bit of technical names that can be introduced, though they are of historical importance. Then is type 2 hypersensitivity reaction, which is also called as molecular mimicry. Two very classical examples that I would like to remember for this is one is rheumatic fever, and second is that initial part that I told, that was mismatched blood transfusion. Mismatched blood transfusion, however, is not the most common complication seen with blood transfusion. So can you comment regarding what is the most common complication of blood transfusion? Okay, the first one is myasthenia gravis. Blood transfusion mismatched is given already. M is myasthenia gravis, then mismatched blood transfusion and the remaining ones. Yes, guys. Can I have answers to what is the most common complication of blood transfusion? And then if you give massive transfusion, what will be the complications from electrolyte perspective that would be seen? Yeah, it is febrile non-hemolytic transfusion reaction. This is one of the questions that has been asked. Second is massive transfusion will result in development of citrate toxicity. This was your last time's exam, so that would be development of hypocalcemia due to massive transfusion. Then is death due to death after blood transfusion. Somebody had commented taco, that taco is the cause of death after blood transfusion. It is not trolley, it is transfusion related acute lung injury. Nahi, it is taco, transfusion associated circulatory overload. And then would come the aspect of dilutional coagulopathy can happen in a patient. So ये क्वेश्चन था जो था ट्रायड और डेथ, जो कि लास्ट टाइम के इनीसेट एग्जाम में था, जिसको लोग बड़ा कंसेप्चुअल पेपर बोल रहे थे, है ना, कि ट्रायड और डेथ पूछ लिया है. तो सिंपल सा है ना, ट्रायड और डेथ वुड बी रिलेटेड टू coagulopathy ना, बिकॉज व्हेन यू लूज हीट फ्रॉम द बॉडी, क्योंकि जब बॉडी से खून निकलेगा तो गर्मी कम हो जाएगी. So there would be hypothermia, there would be coagulopathy, and there would be metabolic acidosis that would be developing. What I have done here is I've compiled all the MCQs related to blood transfusion at a single place, and two must examples of type 2 hypersensitivity that they love to ask is always mismatched blood transfusion, and second one is rheumatic heart disease, where we have that fish mouth appearance of the heart valves due to mitral stenosis. Okay, yeah, hypothermia, acidosis, and coagulopathy. 4 and 6 MCQs covered at the moment. माइस्ट्रा ग्रेविस के लिए आपने बताना है इन्वेस्टिगेशन और चॉइस क्या होती है. Yeah, lethal triad also. It's also called as lethal triad. Yes, guys. More people, please. What is the investigation choice for diagnosis of myasthenia gravis? लास्ट टाइम आपका केस दिया था ना, सारे डी वाले फीचर्स दे दिए, तो उसने डिप्लोपिया, डिसार्थरिया, डिस्निया, development or diurnal variation of weakness with increased symptoms in the evening hours. So can you quickly comment regarding like what is the IOC for diagnosis of myasthenia gravis? Single fiber electromyography, na? SFEMG. हाँ जी, हाँ जी. There's SFEMG showing a decremental response. Good. Then is GPS, which is good pasture syndrome, in which you will be having anti-basement membrane antibodies. Then is Graves disease. Graves की antibody बता दो फटाफट से. What is the antibody in Graves disease? Yeah, single fiber electromyography. More people, please. Can you tell me the antibody for Graves disease, which is also an example of type 2 hypersensitivity reaction? Yes, guys. Graves की antibody. ऑप्शन दूं? ऑप्शन की जरूरत नहीं पड़नी चाहिए. आई थिंक अभी तो मतलब देयर इज नो नीड फॉर एनी एंटीबॉडी. नो. यस यस, वेटिंग फॉर योर आंसर्स देयर. हाँ, माइस्थेनिया ग्रेविस में मस्क नहीं होती ना. एंटी फर्स्ट एंटीबॉडीज एंटी, यहाँ पे जो एंटीबॉडी है माइस्थेनिया ग्रेविस की बोल रहे हो ना, वो तो that is anti-acetylcholine receptor antibody is a specific test, and then is anti-musk antibody for which we don't need to do a thymectomy. हाँ जी, हाँ जी. It is LATS antibody. The alternative name for the antibody is TRAP, that is TSH receptor stimulating antibody. ये बताया हुआ है यार. मतलब ग्रेव्स की एंटीबॉडी और हैशिमोटो की एंटीबॉडी तो हमेशा पूछता ना. तो ग्रेव्स की एंटीबॉडी इज ट्रैप, दैट इज टीएसएच रिसेप्टर स्टिमुलेटिंग एंटीबॉडी. टीएसएच रिसेप्टर स्टिमुलेटिंग एंटीबॉडी, which is also called as LATS, long acting thyroid stimulating antibody. So some of you said LATS. I'm okay with that. Technical name is TRAP, TSH receptor antibody. Then would be ITP, idiopathic thrombocytopenic purpura, where again you would be having both. It's an example of type 2 hypersensitivity reaction. मुझे acute ITP का treatment बोल देना. How would you manage acute ITP? Options दे देता हूँ: platelet transfusion, steroids, IVIG. Can you select one, please? We will come to a bit type 5 now. Type 5, why like sometimes it may be called as type 5 hypersensitivity. So that is up on the agenda. When I discuss type 5 separately, ना उसमें आएगा ये वाला. Yes, guys. Can you tell me regarding what is the treatment for या सपोर्टिव मतलब क्या? सपोर्टिव मतलब क्या? प्लेटलेट ट्रांसफ्यूजन देंगे क्या? इसमें नहीं देंगे ना. प्लेटलेट देंगे तो एंटीबॉडीज उसको डिस्ट्रॉय कर देंगे. सो इफ द प्लेटलेट काउंट इज वेरी लेस, देन वी विल हैव टू गिव इंट्रावेनस इम्यूनोग्लोबुलिन्स फॉर दिस पेशेंट, एंड प्लेटलेट ट्रांसफ्यूजन इज कॉन्ट्राइंडिकेटेड. And in chronic suppurative, it is supportive. Supportive का मतलब है drugs like L-Trombopac can be given to the patient, or we can, like, we have to increase the amount of platelets, and the last resort in this patient is obviously steroids. And most of the time ITP will show us spontaneous resolution, so there is no need of splenectomy in the patient. So L-Trombopac and then steroids would be given, but in acute we will not give steroids, and we will not give platelet transfusion as well. Then is pemphigus. Pemphigus is that pemphigus vulgaris, in which the antibody that is present, क्योंकि type 2 की बात हो रही है ना, तो antibody तो पूछेगा ही. I mean, because it is type 2 hypersensitivity reaction, that is why the name will be anti-desmoglein 3 and anti-desmoglein 1 antibody that would be responsible. Yeah, we have monoclonal antibodies also available for this. And then for pernicious anemia, which antibody would be responsible? Quick answers, please. Pernicious anemia is the leading cause of development of vitamin B12 deficiency. Leading cause of vitamin B12 deficiency is not alcoholism. It is autoimmune gastritis. I think I've given the hint also. What is the antibody responsible for pernicious anemia? There are answers would be anti-intrinsic factor antibody and anti-parietal cell antibody. The name is anti-intrinsic factor antibody and anti-parietal cell antibody. तो B12 absorb नहीं होगा, so this condition will also contribute to development of that macrocytic anemia or megaloblastic anemia, which happens to be one of the leading causes of development of vitamin B12 deficiency. So type 2 hypersensitivity में mnemonic तो पता ही आपको, my blood group is RH positive, so that will not be an issue. And usually the questions are asking regarding the individual details of the topic, including the blood transfusion questions that I have covered at the moment. Next is type 3 hypersensitivity reaction. that is SLE, serum sickness and Schick's test. Schick's test is what we do for diagnosis of diphtheria. तो आजकल की डेट में तो यूज नहीं करते, but still it's an intradermal test that is done. Then is Henoch's colon purpura, that will always be having extensor purpura. This is one of the commonest types of vasculitis in Western population. So most of the time the image based question will be given to you of a purpuric rash, and this purpuric rash will always be given in the patient, yeah, pernicious still tops. And extensor purpura, whenever it will be given on the buttocks of the patient, on the back of the thigh of the patient, and on the legs of the patient. So Henoch's colon purpura is always a extensor purpura. Then is Arthur's phenomenon, which will cause joint pain. Then is reactive arthritis. Can you tell me the organism causing reactive arthritis? This is a guy, he went to Bangkok. He had unprotected sexual exposure. Yeah, Henoch's colon purpura is IgA mediated. But he'll ask you about extensor purpuras, and he'll ask you about platelet count, which is normal in this condition. Platelet count is always normal in Henoch's colon purpura. It is a vasculitis. Normally vasculitis is due to thrombocytopenia, but here it will be because it is a non-thrombocytopenic purpura. Yeah. Can't see, can't pee, can't walk. The organism is chlamydia, and the manifestation is that of reactive arthritis, urethritis, uveitis, conjunctivitis, and arthritis that would be present and would be responsible for this presentation. The next example is PSGN, post-streptococcal glomerulonephritis. Though we have discussed about it, but I would still request you to let me know regarding the light microscopy finding of PSGN, electron microscopy, and immunofluorescence finding. Immunofluorescence I will write because that is very easy. Starry sky. Can you tell me the electron microscopy and then subsequently the light microscopy finding here of PSGN? They always ask about it. PSGN, light microscopy, electron microscopy, immunofluorescence. शार्प इज अ निमोनिक. वो आजकल ऐसे तो बोलता नहीं ना कि ऑल आर एग्जांपल ऑफ टाइप 3 हाइपर सेंसिटिविटी. यस गाइस, या रूल ऑफ 5 फॉर लेप्रा. यस 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 यस. टाइप 1 लेप्रा रिएक्शन इज टाइप 4 हाइपर सेंसिटिविटी. तो आपने बोला तो मैं मेंशन कर रहा हूँ. And then is type 2 lepra reaction, which will be seen after the treatment is started. It is type 3 hypersensitivity reaction. And ultimate number we need to achieve is 5. 1 plus 4 is also 5 and 2 plus 3 is also 5. So that's again a basic concept. पोडोसाइट्स नहीं होता भाई. पोडोसाइट अब PSGN मिनिमल चेन डिजीज थोड़े ना डिस्कस कर रहे हैं यार. The electron microscopy finding in this particular case would be presence of subepithelial. Endothelial नहीं, वो lupus में होता है. It is subepithelial. It is subepithelial humps that would be present in this patient. You might say the word electron dense deposits. And then is the light microscopy finding. The light microscopy in this condition would be hypercellularity of the glomerulus. It is hypercellular glomerulus, and along with that the light microscopy finding would be obliteration of the Bowman space. And because of the obliteration of the Bowman space तभी इधर oliguria हो जाता है, anuria हो जाता है. So light microscopy findings would be hypercellular glomerulus, obliteration of the Bowman space. Electron microscopy would be subepithelial deposits, and then immunofluorescence is starry sky. वो जो आप food processes वगैरह बोल रहे थे, that is a feature that is seen with nephrotic syndrome in the patient. So at the moment what I've tried to do is describe the important type of hypersensitivity reactions which are usually asked in the exam. Type 1, type 2 and type 4 is what I've catered to. Type 1 is pretty simple, that is the allergic reaction. Now is the must know ones. Rheumatoid arthritis is an example of type 3 hypersensitivity reaction. Don't mix it with HLA-DR4 positivity. For rheumatoid, where you get involvement of the small joints of the hand, PIP, MCP and the wrist, it is bilateral involvement in a young female with morning stiffness. It is type 3 as well as type 4 hypersensitivity. Then is hypersensitivity pneumonitis, which is farmer's lung, which is type 4 hypersensitivity. SLE में 2 और 3 दोनों चलता है, but single best answer would be type 3 hypersensitivity for systemic lupus erythematosus. And then is transplant rejection. This I think you guys can comment here. तीनों एक साथ बोल देना please. I would like everybody in the chat to comment on. ग्रेव्स मत बताना. ग्रेव्स तो किसी ने बोल भी दिया था कि ग्रेव्स टाइप 5 भी बोलते हैं क्योंकि स्टिमुलेटरी एंटीबॉडीज होती हैं. Yes guys. Answers for transplant rejection. हाइपर एक्यूट तो प्री फॉर्म्ड एंटीबॉडी से होगा, प्री फॉर्म्ड एंटीबॉडी से होगा तो टाइप 2 हो जाएगा ना, क्रॉनिक 4 हो जाता है और एक्यूट में दोनों होंगे, 2 as well, 4, that is the humoral and the cellular component would be present. Yeah, I think most guys were able to answer this spot on. ये वाला जो टेबल है यार, ये कभी गलत नहीं होना चाहिए. I mean the details related to this common hypersensitivity, common conditions, including that of lepra reaction that was put up, are like easy questions which are to be remembered. At least एक तो फंसता है इसमें से. चलो लास्ट करेंगे, ये आप लोगों ने बोलना है. आई थिंक दिस आई हैव मेड यू गाइस डू द प्रैक्टिस ऑफ दिस. सो आई विल टॉक अबाउट दिस इम्यूनिटी डिसऑर्डर्स नेक्स्ट एज द लास्ट थिंग फॉर टुडे. यस गाइस, ऑटोइम्यून डिसऑर्डर्स में व्हाट इज द मोस्ट सेंसिटिव स्पेसिफिक, तो एंट्री लेवल क्राइटेरिया तो मतलब एंटी न्यूक्लियर एंटीबॉडी होता है, इसको तो एंट्री लेवल क्राइटेरिया बोल देंगे. 1:80 के ट्रांसलोकेटेड 1:80 टाइटर पे. देन इज द मोस्ट स्पेसिफिक वन, दैट इज, आप लोग हेल्प कर दो यार, डबल स्टैंडर्ड डीएनए मेरे को भूलना नहीं चाहिए था, बट एनीवे द मोस्ट स्पेसिफिक वन इज एंटी स्मिथ एंटीबॉडी. फॉर द सेकेंड वन, फॉर मॉनिटरिंग द कोर्स इट इज डबल स्टैंडर्ड डीएनए. Yes, can you tell me the one for neonatal lupus? I'll hold for a while so that you and me align on the chat. Yes, guys. हाँ जी, neonatal lupus antibody. Very good. Neonatal is the Rho antibody. Yes, anti-RO antibody. और ये क्या करती क्या है, तो neonatal lupus में it will result in development of complete heart block in the patient. The manifestations would be complete heart block where AV node of the patient would be destroyed. So number of P waves or R waves in the ECG will not be matching. Yeah. U1 थोड़ा सा मिक्स कर रहे हो यहाँ पे. It is not U1 RNP. अगर आपने U1 RNP बोला था ना, that is for mixed connective tissue disorder. आपने मिक्स कर दिया डेटा को. So I hope that mistake will not happen. Good that you commented here, क्योंकि फिर गलती नहीं होगी. For psychosis is anti-ribosomal P. Anti-ribosomal P, yeah. And for drug induced it is anti-histone antibody. So this is again something which is very simple and straightforward to be remembered for the antibodies that are related to lupus. Very good. Then is S-Sjogren syndrome, where we will be having anti-Rho antibody, but the diagnosis will be based on salivary gland. In fact, it is a minor salivary gland biopsy, so we will be taking a sample from the inside of the mouth. That is, labial biopsy would be done, and along with that, anti-SSA antibody or Rho antibody would be present. So the combination of the two will help in diagnosis of S-Sjogren syndrome, where eye involvement will be demonstrated by putting fluorescent dye, lissamine green, and rose bengal dye in the patient. So dry and dry mouth both need to be demonstrated. For scleroderma, if it is diffuse versus limited, can I have answers, please? Okay, this is the last entries that I'll be discussing with you for today. Diffuse scleroderma and limited scleroderma. Can I have answers, please? मतलब वही है, crest syndrome है ना. This is crest and then is the diffuse variety. Yes, guys. Yeah, the first one would be given as anti-topoisomerase. And the next one, the crest, would be called as anti-SCL antibody. That anti-SCL antibody, this would be called as anti-centromere antibody. The anti-centromere antibody is like beginning with C, and the crest syndrome is also beginning with C. So these are a couple of details, guys, for today's session that I held with you. And the objective was to take care of some of the aspects of GPath which are like well read by you, but I thought I'll just make you brush them up. So I've done them over a period of almost like 2 hours or so, and I hope that this session will be productive. So I'll see you again. I have a session of medicine also that is lined up on 11th, and that would be, we'll do the entire medicine revision in about approximately 3.5 to 4 hours. So with this, I end the discussion for today, and I thank you for joining for today. Yeah, skin tightening would be a manifestation here. Okay, guys, take care. If you have any queries, I'll just wait for another 5 seconds in case you have any issues to discuss. Okay, so see you guys. Take care. Bye bye. Yeah, the next one would be scheduled on 11th. That would be in the evening, 9 p.m. onwards. Take care. Bye bye.